we are looking at the skeleton of the upper limb, especially the clavicle bone, which is important for transmitting the weight of the upper limb towards the axial skeleton in case there is a fall on the outstretched hand. Let us look at a player here. This is a player which is a case of fall on the outstretched hand, and the weight of the upper limb is supposed to be transmitted towards the axial skeleton. There are involvement of some of the ligaments, and one of the ligament is the humerus sending the weight towards the scapula, which will then transmit it towards the clavicle. That is the most important ligament here, which is called as coracoclavicular ligament. So here is the coracoclavicular ligament, as you see, which is for the transmission of the upper limb weight towards the clavicle bone. Now the clavicle is transmitting weight towards the axial skeleton, while some ligaments, and one important is called as the costoclavicular ligament. So here it is between the clavicle and the first rib there. This clavicle bone is the only long bone in the body which is disposed in a horizontal direction. It is the only long bone which will have two primary center of ossification for the development of the shaft, and it is subcutaneous throughout, and it is also said to have no bone marrow. When we talk about the fracture of the clavicle, it is mostly happening in the middle 1/3 of the clavicle, especially at the junction of the medial 1/3 and the lateral 1/3. And here we can mark the clavicle bone on this X-ray. As you can see, it is going to be related with the bone sternoclavicular joint, and their acromion process of scapuloacromioclavicular joint, and just below that, at the lateral 1/3 below that, is the coracoid process of the scapula. That comes as a question here. So medially is the sternoclavicular joint, which is actually saddle synovial joint, and laterally there is a acromioclavicular joint, which is a plain synovial joint. Both of them are involved in shoulder abduction, and then you can also see that this is the point where there can be fracture of clavicles, the junction of the lateral 1/3 and medial 2/3 of clavicle. Here in this diagram, we are going to talk about the various type of the epiphyses, which are generally classified as the pressure epiphysis, or that could be the traction epiphysis, or it could be the atavistic epiphysis, and also the aberrant epiphysis. Now, the pressure epiphyses are under the pressure of the weight transmission. For example, you can see the head of the humerus and the condyle of the humerus. So here we see the head of the humerus, which is articulating with the glenoid cavity of the scapula, making the shoulder joint, ball and socket joint. And here we can see the lateral condyle of the humerus, which is the capitulum, and then it is the trochlea, which is on the medial side. Now, these are under the pressure of weight transmission, so pressure epiphysis. Whereas when we talk about the traction epiphysis, which is coming because of the pull by some muscles, for example, you have sit muscle sitting on the greater tubercle and subscapularis muscle inserting on the lesser tubercle. So these muscles are pulling the bone and causing the traction epiphysis. We'll talk about the sit muscles later in the discussion. The supraspinatus, infraspinatus, and teres minor. Along with these two traction epiphyses, you have two more to discuss. Here you have the medial epicondyle, and there you have the lateral epicondyle. You will find that medial epicondyle is the common flexor origin. The anterior forearm muscle, flexor muscles, take origin from here, and the lateral epicondyle is the common extensor origin. From there, the posterior forearm muscles are taking origin. Now, these lateral medial epicondyle and the lesser greater tubercle are called as the traction epiphysis because they appear due to traction by some of the muscles. When it comes to atavistic epiphysis, the coracoid process of scapula is considered as the atavistic epiphysis. It is actually a small bone in the lower animals, and it is fused with the scapula main bone in the humans. So a bone which is a separate bone in the lower animals, but in humans which has fused with the main bone, like the coracoid process, it is called as atavistic epiphysis. Let us talk about the aberrant epiphysis now. For that, we have to come to the metacarpal bones. We need to understand that the head of each metacarpal is having one epiphysis, but for the first metacarpal, the epiphysis is at the base. Few people in the population who can have one epiphysis at the head of the first metacarpal. In that case, we'll call it as aberrant epiphysis because it is not normal and it is an aberration from the normal population. Talking about the brachial plexus, which is going to supply the upper limb, you will have the 5 root values coming from the cervical and thoracic spinal cord. There is a cervical enlargement in the spinal cord to keep some of the neurons which will send axons towards the upper limb brachial plexus, and there are two questions. One will be asking the cervical enlargement root value, which is starting cervical 3 and reaching thoracic 2, and the other will be asking the 5 root values which will come towards the brachial plexus that will be lying within this range, and they are starting with 5, C5, then you have 6, 7, 8 and also T1. Let us look at the 5 root values of brachial plexus coming from the cervical enlargement in the spinal cord in the next diagram now. The brachial plexus is lying in the neck region and passes behind the clavicle bone and enters the axilla. There will be the roots and trunks which are lying in the neck region, whereas the divisions will be passing behind the bone clavicle, and then cords and branches are in the axilla. The roots are C5, 6, 7, 8, T1 in the neck region, as you can see, and then they will be joining to form upper, middle and lower trunk. Upper, middle, lower trunk are present in the neck region, whereas the divisions are passing behind the bone clavicle. Each trunk is giving one anterior and posterior division, and there are such 3 anterior and 3 posterior division. Total 6 of them will be passing behind the bone clavicle, and then they join to form cords of the brachial plexus. There are 3 cords of the brachial plexus, namely the lateral cord, posterior cord and medial cord, named according to the relation with the axillary artery in the axilla. And if we see, the lateral cord of the brachial plexus in the axilla will continue as the musculocutaneous nerve, whereas the posterior cord of the brachial plexus will continue as the radial nerve, and the medial cord of the brachial plexus will continue as the ulnar nerve. Whereas the long thoracic nerve to serratus anterior is coming directly from the roots of C5, C6, C7 in the neck region itself. The musculocutaneous nerve is the nerve of the arm, supplying some muscles there. The radial nerve is going towards the radius bone, and the ulnar nerve runs towards the ulna, and the median nerve is running in the midline. Now, this is a schematic diagram of the brachial plexus. You have roots and trunks in the neck region, the divisions passing behind the bone clavicle, and the cords and branches are in the axilla. As we said, the roots of C5, 6, they are going to join form the upper trunk, the middle value C7 for the middle trunk, and the lower trunk has root value C8, T1. It is understood that the upper root value C5, 6 will be supplying upper muscles, like there will be the shoulder, scapular, arm muscle. There will be compromise in Erb's palsy, which is the injury of C5, 6, whereas the distal muscles like the hand muscle will have distal root value, for example C8, T1, and which is compromised in Klumpke's palsy, involving the lumbrical and interossei muscles there. When it is the proximal root value C5, 6, it will go into some proximal nerves like the musculocutaneous and axillary nerve, and if it is the distal root value C8, T1 will be going to the distal nerves like the ulnar nerve has root value C8, T1. But there are some nerves which can have all the 5 root values. For example, the radial nerve is 1 and median nerve is the other. They have all the 5 root values of brachial plexus, which is C5, 6, 7, 8 as well as T1. Out of the trunks, only the upper trunk will be giving 2 branches in the neck region, that is the suprascapular nerve to supply scapular muscles and nerve to subclavius to supply subclavius muscle. Otherwise, middle and lower trunk don't give any branch in the neck region. Regarding the divisions and the cords, we will be talking about them in next discussion. But here we want to know what is the dermatome of the thumb, that will be proximal root value, and what is the dermatome of the little finger, which will be distal value, and what is the dermatome of the middle 3 fingers. Let us discuss that now in a diagram. Here is the developing baby, and you have to understand that if we are talking about the thumb, it will be proximal dermatome, which is C6 dermatome, and if you are talking about the middle 3 finger, that will be C7 dermatome, and we are talking about the lower little finger, then it will be C8 dermatome. Let me show you one diagram for the same. It is the thumb, which is C6 dermatome, and C7 are the middle 3 fingers, and C8 is the little finger, maybe on the anterior side or maybe on the posterior side. Talking about the myotome, the C5, C6 root value that is supplying the proximal muscles, that could be shoulder, scapular or the arm muscle. The arm muscle like biceps, which is working for elbow flexion, and the shoulder scapular muscle, which are working for shoulder abduction. In case of Erb's palsy, when we have injury of C5, C6 root value, the patient finds difficulty in shoulder abduction and the elbow flexion. While if we are going to fold our finger, they are the distal muscles, the hand muscles, and if we are going to spread and close the finger, that is the interossei muscle, having the T1 root value and C8 root value. They are compromised in Klumpke's palsy, resulting in a claw hand deformity. During development, the upper limb and lower limb are rotating, and we see the upper limb limb is rotating laterally by 90 degrees so that the thumb will come lateral in the anatomical position, whereas the lower limb is rotating medially by 90 degrees so that the great toe will come medial in anatomical position. Also, you will notice that the lower limb is folding posteriorly, so the flexor compartment will be posterior in the lower limb, whereas the upper limb is folding anteriorly, so flexor compartment will be anterior for the upper limb. As we can see there, the upper limb folding is anterior, so anterior compartment or the flexor compartment, and whereas the lower limb is folding posterior, so flexor compartment will be on the posterior aspect. And then obviously the anterior compartment of the lower limb will become the extensor compartment, whereas for the upper limb, the posterior compartment will be the extensor compartment. Now let us look at some more details of the brachial plexus. It is understood that if the upper trunk is damaged, there will be Erb's palsy involving the root value C5, C6, whereas in Klumpke's palsy, lower trunk is involved and involving the root value C8, T1. There is a Erb's point which is meeting of the 6 nerves here, which are root of C5 and root of C6. Then it is the suprascapular nerve and nerve to subclavius, and then it is the anterior division of the upper trunk and the posterior division of the upper trunk. So total 6 nerves are meeting here, and that could be the site of the Erb's palsy lesion. So here is the root of C5-6, and then this suprascapular nerve to subclavius, and then the anterior posterior division of the upper trunk, the Erb's palsy. Let's discuss some of the details then. Here is a table which is talking about a person having the Erb's palsy, which is Policeman-Tip hand deformity. There is injury of the lower trunk, so some of the nerves will be involved with the root value C5-6. That could be the suprascapular nerve, axillary nerve, musculocutaneous nerve, or partial injury of radial nerve. The etiology could be a birth injury, where is a difficult labor and we are trying to pull the baby out, and there is undue separation of head and shoulder. The undue separation of head and shoulder can also occur in sports injury, fall on the shoulder. Then there will be pulling of the upper trunk leading to Erb's palsy. Here you can see a patient suffering from the Erb's palsy, and you will find Policeman-Tip hand deformity. There are some muscles with the root value 5-6 compromise, so difficulty in shoulder abduction and lateral rotation. In that case, the other opposite muscles become more powerful and shoulder remains in ADD, adduction deformity, and merely rotated as well. The elbow muscles which do flexion are compromised, so elbow remains in extension deformity, and the hand muscles which are working for supination are compromised, so the forearm and the hand remain in prone posture. This is called Policeman-Tip hand deformity, a typical feature of Erb's palsy. And here we are looking at a case of the lower trunk injury, which is the Klumpke's palsy. Specifically, the T1 root value is injured, though there is also a compromised C8, and some nerves having the root value may be compromised. That could be partial injury of median nerve and almost total injury of ulnar nerve, and also involvement of T1 sympathetic fibers, leading to some features of Horner syndrome, which is meiosis and ptosis. Some muscles supplied by the T1 root value have been compromised. On the other hand, what is the etiology? Etiology could be a birth injury or a sports injury. There was a difficult labor, you are trying to pull the baby out, and there is some hyperabduction injury, which can also happen. A boy playing and falling from a tree, trying to catch hold of branch, and there is again hyperabduction injury, which is pulling the lower trunk, and some of the hand muscles will be compromised, and which could be lumbrical interossei. Now, what is this deformity? That is claw hand deformity. Let us explain how that happens. Normally, there are 4 lumbricals and 4 palmar interossei and 4 dorsal interossei, total 12 muscles. Together, they are doing 2 functions: the flexion of the metacarpophalangeal joint and the extension of the interphalangeal joint. And normally, they are going to balance the anterior and posterior forearm muscles. Now, we want to know how this lumbrical and interossei are causing the interphalangeal extension. Actually, they are working with a muscle which is called as extensor digitorum. The extensor digitorum is a muscle of the posterior forearm, and it is going to send some dorsal digital expansion on the dorsum of the fingers, which is important for interphalangeal extension. And that is where are inserted the lumbrical and interossei. They'll also be helping for interphalangeal extension. So here we have magnified the dorsal distal expansion. This is the distal phalanx, middle phalanx, and proximal phalanx. And you see that it is basically the extensor digitorum tendon which is producing this dorsal distal expansion. But here are inserted the interossei and the lumbrical muscles which are coming from anterior side. As they come to the posterior side, insert here, they can help the extensor digitorum in interphalangeal extension. Now, in Klumpke's palsy, lumbrical interossei are not working, so anterior posterior forearm muscle become more powerful. You will see posterior forearm muscle, which is extensor digitorum, is now leading to metacarpophalangeal hyperextension, and then the anterior forearm muscle, which is flexor digitorum, especially flexor digitorum profundus, is leading to interphalangeal flexion, which is normally balanced by the lumbrical interossei. interossei. If you cannot do IP extension, IP joint go into flexion, and if you cannot do MCP flexion, then the MCP joint goes into the hyperextension. That is claw hand deformity. As you can notice that ulnar nerve is going to supply out of 12 muscles, the 10 of them, and if ulnar nerve is not working, then 10 muscles are not working. As you can see, there is interphalangeal flexion, which is caused by the flexor digitorum profundus on the anterior forearm muscle, and you can see there is a MCP hyperextension caused by the extensor digitorum, which is now unopposed because normally they are balanced by lumbrical and interossei in the hand. If the lumbrical and interossei are paralyzed, these muscles become more powerful, leading to deformity. Once again, we come to the discussion of the brachial plexus, and we are going to talk about the cords and branches, this time in the axilla. It is understood that the upper, middle, and lower trunk, they were present in the neck region, and each of them, they were giving divisions. There is one anterior division and one posterior division. When we see that the anterior division of the upper trunk and middle trunk, they are joining to form the lateral cord of brachial plexus in the axilla, whereas the posterior division of all the three trunks, they join to form the posterior cord of brachial plexus in axilla, and the anterior division of the lower trunk will continue as the medial cord of brachial plexus there. Now let us magnify this area to have more details of the cords having a relation with the axillary artery in the axilla. As it is understood, the lateral cord of the brachial plexus will be continuing laterally to the axillary artery in the axilla, and then it will become musculocutaneous nerve, whereas the posterior cord of brachial plexus will be passing behind the axillary artery and continue as the radial nerve. Medially, you have the medial cord, and then it will be continuing as the ulnar nerve, whereas the median nerve is contributed by lateral cord and medial cord of brachial plexus and running anterior to the axillary artery there. As you can see here, the posterior cord of brachial plexus is giving the radial nerve, which is coming behind the mid shaft of the humerus in a radial groove, and then comes in front of the lateral epicondyle of the humerus bone and become a content of the cubital fossa, giving two terminal branches. One is cutaneous and one is the motor. Now, on the other hand, the medial cord of brachial plexus continuing as ulnar nerve will be passing behind the bone ulna, behind the medial epicondyle. So it is not a content of the cubital fossa. It keeps running with the ulnar bone. As far as the median nerve is concerned, it is contributed by medial lateral cord of brachial plexus and keep running in the midline, and it is definitely a content of the cubital fossa. As it comes to the axillary nerve, which is a branch of the posterior cord of brachial plexus, it will be running related to the surgical neck of humerus. If there is a fractured surgical neck of humerus, the axillary nerve is compromised. If there is a mid-shaft fracture, radial nerve is compromised. If there is a supracondylar fracture, three nerves can be compromised, though the most commonly damaged is the median nerve, and less often will be the radial nerve, and the least often is the ulnar nerve injury in a case of supracondylar fracture. Let us discuss a few branches of the posterior cord of brachial plexus in addition to the radial nerve and axillary nerve now. Actually, we remember them as the stars mnemonic. There is the upper S, lower S, which is the nerves coming under the scapula, supplying the subscapularis muscle. Thus, it becomes a hybrid muscle having two nerves supplied. When it comes to T, T is the thoracodorsal nerve supplying the muscle of lower back, which is the latissimus dorsi inserted into the floor of the bicipital groove. And when it comes to R, R is the radial nerve, which is going to pass behind the bone humerus in the radial groove and is the nerve of the posterior compartment, nerve of the extension, causing extension at the elbow, at the wrist, MCP or interphalangeal joint. When it is about the A is the axillary nerve, which is a branch of the posterior cord of brachial plexus, first run in the quadrangular space, then comes to the surgical neck of the humerus. Now we are looking at the right scapula, which is anterior as well as the posterior view, and we want to talk about some of the muscle taking origin and insertion on the bone. There will be a coracoid process, tip of coracoid process giving origin to the short head of the biceps brachii, whereas the long head of biceps brachii will come from a supraglenoid tubercle, and it is an intracapsular origin for the long head of the biceps brachii. When it comes to the subscapular fossa, you will be seeing the anterior aspect of the scapula. A muscle will be originating here, the subscapularis muscle. When it comes to the medial border of the scapula, anteriorly there is the insertion of the serratus anterior muscle. On the dorsal side of the scapula, you can see the spine of scapula, which is continuous with the acromion process of the scapula there, and you will notice that there's a muscle coming from the supraspinous fossa, which is called supraspinatus muscle, and this is the infraspinatus muscle coming from infraspinatus fossa, and then there'll be a teres minor coming from the lateral border of the scapula. On the the dorsal surface. These are called as the sit muscle, and they'll be sitting on the greater tubercle of the bone humerus, which is articulating with the glenoid cavity there to make the shoulder joint. If you talk about the teres major, it will be taking origin from the lateral border of scapula, but little bit inferiorly, and it is on the dorsal aspect of the scapula. When it comes to the infraglenoid tubercle, it is the origin of the long head of the triceps, which takes origin here, but insertion is on the ulna bone down there. As we look at the spine of scapula, the upper border of the spine of scapula is the insertion of the trapezius muscle coming from the occipital bone and the spines of the vertebra. The insertion of the trapezius is also extending onto the medial border of the acromion process and clavicle bone on the anterior side. In the similar fashion, if you look at the spine of scapula lower border and the outer border, lateral border of the acromion process or the anterior surface of the clavicle bone, that will be the origin of a muscle which is called as the deltoid muscle, and it will be inserted on the deltoid tuberosity on the bone humerus down there. All these muscles will be looking at now one after the other. Now here is the biceps muscle, which is having two heads. The long head of biceps is coming from supraglenoid tubercle and running in the bicipital groove, and then it will be merging with the shorter of the biceps brachii, which is coming from the tip of the coracoid process of the scapula, and both of them belly is formed, and that belly is now coming to insert on the radius bone laterally. As it comes here, it will be inserted on the radial tuberosity, lateral bone, radius bone, but it is sending some bicipital aponeurosis, which will be at the roof of the cubital fossa here. Biceps muscle is a muscle for the flexion of the elbow, and then it is also a powerful supinator. It is supplied by musculocutaneous nerve there. Presently, we are looking at the upper end of the right humerus, showing the lesser tubercle and the greater tubercle, and between the two we have intertubercular sulcus, which is also called bicipital groove because the long head of the biceps brachii muscle is passing through that. The lesser tubercle is the insertion of the subscapularis muscle, which is coming from the anterior aspect of the scapula, insert here, whereas the greater tubercle, more so on the posterior side, will be receiving the sit muscle sitting on the greater tubercle, S for the supraspinatus, I for infraspinatus, and T for the teres minor, muscles making the rotator cuff. As you will find here is the lady between two major, insertion of the latissimus dorsi of the lower back at the floor of bicipital groove, and laterally is the pectoralis major coming from the anterior wall of axilla, and posteriorly you have the teres major, the posterior wall of axilla, attaching to the medial lip of the bicipital groove. So here you can see the lady between the two majors. The lady is the latissimus dorsi coming from the lower back, inserted on the floor of the bicipital groove. When it comes to the pectoralis major, it is attaching to the lateral lip of the bicipital groove, whereas the teres major, which is coming from the dorsal aspect of the lateral border of the scapula, you will find the origin of teres major. Insertion is the medial lip of the bicipital groove, lady between the two majors. Now in the posterior wall of axilla, you will see three muscles, and namely the latissimus dorsi, teres major, and one more which is coming from the anterior aspect of the scapula, which is subscapularis muscle. Whereas on the anterior wall of axilla, you will have two muscles. One is pectoralis major, and undercover of that will be pectoralis minor. So two muscles in the anterior wall of axilla and three muscles in the posterior wall of axilla. Now let us talk more about the pectoralis major muscle here, and it is a large muscle taking origin from the clavicle bone and the sternum bone and the costal cartilages here, whereas the insertion is narrowed down to the lateral lip of the bicipital groove. This muscle has a spiral fiber, as you will see that the upper clavicle fibers are inserted at the lower level, whereas the costal fibers are going up and inserted at the upper level. So there is a total 180-degree spiral fibers. This muscle having the spiral fibers is already a question which has been asked. Pectoralis major is crossing the shoulder joint anteriorly, so it will be causing medial rotation of the humerus bone at shoulder joint and also cause flexion of the shoulder joint, forming the anterior wall of the axilla, and undercover of that assisting muscle is pectoralis minor. Both of them are the anterior wall of axilla. Let us look at one more example of the spiral fiber. We have told that one of them is a pectoralis major, the other is latissimus dorsi, coming from the lower back, that is also inserted here to the floor of bicipital groove, but after 180-degree spiral fibers. The lower fibers come up and the upper fibers will go low. We'll be looking at this muscle once again. Here is a diagram which is telling you about various type of the pinnate muscle muscle or the different type of the muscle fiber arrangement. For example, here you can see there are some strap muscles which are seen in the anterior neck region, the muscles running parallel with each other for some distance, and that could be sternohyoid or thyroid muscles. As you talk about the triangular muscle, that could be the temporalis muscle inserted on the coronoid process of the mandible. And then if you are talking about cruciate muscle, that could be sternocleidomastoid, coming from sternum clavicle to the mastoid bone. If you are talking about the digastric muscle, anterior belly, posterior belly of digastric. If we are talking about tricipital muscles like the triceps muscle here, having 3 bellies. Then it is about the unipinnate, which could be flexor pollicis longus. It is the bipinnate muscle, which could be the dorsal interosseous, or it is the multipinnate muscle, that could be the deltoid muscle here. And when it comes to circumpinnate, it is in the lower limb, that is the tibialis anterior muscle. And then we look at the origin insertion of the serratus anterior muscle. You will see that serratus anterior is taking its origin from the upper 8 ribs, that is lateral surface, and then they will be inserted into the medial border of the scapula anteriorly. As you see, this muscle is capable of pulling the scapula forward, which is called protraction of scapula, that is involved when you are trying to push the wall. And also it is working with the trapezius muscle for overhead abduction, to take your arm above the head at the shoulder joint. This muscle will be forming the medial wall of the axilla along with the upper 4 ribs, whereas the lateral wall of axilla is the humerus bone. Let us see what will happen if the serratus anterior has been paralyzed. There will be winging of scapula. You are asking this patient to push the wall, and that will require the protraction of the scapula. As you can see, it is already happening on this side of the body, but on the other side, serratus anterior is paralyzed. So there will be abnormal prominence of the medial border of the scapula, which is normally pulled anteriorly by serratus anterior. If serratus is not working, then medial border of scapula become more prominent, called winging of the scapula. Here we look at some of the muscles on the posterior aspect of the back, and you can see the sit muscles sitting on the greater tubercle. Above the spinal scapula, supraspinatus is the origin, and below the spine is infraspinatus origin, and lateral border of the scapula, teres minor origin on the dorsal aspect, and they all insert on the greater tubercle of the bone humerus, making a musculo-tendinous rotator cuff with the help of one more muscle from the front, which is called subscapularis muscle. We will see rotator cuff in a short while. At present, you can also see a triangular muscle, which is called as the trapezius muscle, taking its origin from the skull occipital bone and also from cervicothoracic spine here. The insertion is on the scapula and the clavicle bone. Scapula, it is the superior border of the spine of scapula, inner border of the acromion process, and clavicle, posterior surface of clavicle. It is like a J-shape insertion. The muscle can pull the scapula and the humerus bone, clavicle bone up, which is important for shrugging the shoulder, and the nerve supply is spinal accessory nerve. If the spinal accessory nerve is damaged, then there will be difficulty in shrugging the shoulder, and there will be drooping of shoulder. There will also be problem of overhead abduction. When it comes to deltoid muscle, it is running parallel to the trapezius muscle insertion. Here is the origin of the deltoid muscle, which is lower border of the spine of scapula and the outer border of the acromion process and the anterior surface of the clavicle bone. There is the outer J and there is the inner J. Inner J is the insertion of trapezius muscle, and outer J is the origin of the deltoid muscle, which is a multipinnate muscle and inserted on the deltoid tuberosity on the bone humerus. This muscle is for the shoulder abduction and supplied by the axillary nerve there. When we talk about the latissimus dorsi muscle, it is coming from the thoracolumbar fascia and thoracolumbar spine, and also the origin taken from the inferior angle of scapula and the hip bone, which is iliac crest of the hip bone. Insertion is very narrow, and it is anterior to the bone humerus, and that is the floor of the bicipital groove. As we suggested, the fibers will be taking 180-degree spiral fiber. The lower fibers will be going inserting above and vice versa. Here also you can see the origin of the latissimus dorsi muscle of lower back, and which is taking its origin from the lower thoracic, and the lumbar spine origin is also from the iliac crest of the hip bone and also inferior angle of the scapula. Insertion is on the anterior aspect of the bone humerus, floor of the bicipital groove, and spiral fibers, 180-degree spiral fibers. Whereas this is the insertion origin of the trapezius muscle. Origin is from the skull bone, occipital bone, and also the cervicothoracic spine. Insertion is the superior border of the spine of the scapula, which is also extending on to the middle border of the acromion process and the posterior surface of the clavicle bone, the inner J of the insertion of the trapezius muscle. And this is the deltoid muscle, which is a multipinnate muscle inserted on the deltoid tuberosity on the bone humerus, but the origin is actually from the anterior surface of the clavicle bone and the lateral aspect of the acromion process, and then the spine of the scapula posteriorly. You have to understand that this muscle will be having the lateral fibers, which are for the shoulder shoulder abduction, and the anterior fibers which can pull the humerus bone medial, so there will be medial rotator, whereas the posterior fibers of the deltoid are pulling the humerus laterally, so they are lateral rotator. So this one muscle, multipentate muscle, can be a middle rotator anteriorly and lateral rotator posteriorly, and if the middle fibers, they are powerful abductor at the shoulder joint. When it comes to the shoulder abduction, we'll find that there is a movement which is lateral rotation of the scapula. In that, there are two muscles involved. One is the serratus anterior, which is causing protraction of the scapula, and also rotate the scapula laterally for the shoulder abduction, assisted by the upper back muscle, which is the trapezius muscle, which is basically a retractor of the scapula. So protractor, retractor, together they work and rotate the scapula laterally for the overhead abduction, taking the arm from 90 degree to 180 degree of abduction. You can also see that the trapezius muscle is a retractor of the scapula, which is bringing the scapula back towards the midline, along with the muscle here, which are called as the rhomboid major minor, whereas the serratus was pulling it anterior, which is called as protraction of scapula. When we discuss the shoulder abduction, we have to understand that there is the movement of the humerus bone, which is elevation of the humerus, and also there is a lateral rotation of the scapula. See, 60 degree of the contribution is by the lateral rotation of scapula, and 120 degree is by the elevation of the humerus bone. Total 180 degree of abduction can be done at the shoulder joint in ratio of 1:2. Scapula bone moving half the distance and the humerus is double the distance. So supraspinatus is the initiator of the abduction, moving the humerus bone 0 to 15 degree of the abduction, and it is supplied by suprascapular nerve. When it comes to 15 degree to 90 to 100 degree, that is the next muscle, which is the deltoid muscle, and supplied by axillary nerve. When it comes beyond that, that is the overhead abduction, you need two muscles. One of that is the trapezius, which is taking it more than 90 degree to 180 degree. That is supplied by spinal accessory nerve, assisted by serratus anterior, which is also working 90 degree to 180 degree, supplied by long thoracic nerve to serratus anterior. Rotator cuff is a musculotendinous support to the shoulder joint capsule and is contributed by sixth muscle. There is a supraspinatus, infraspinatus, and teres minor, origin from the scapula, inserting on the greater tubercle of the bone humerus. And there is one S muscle which is coming from anterior aspect of the scapula. Under scapula, that was a subscapularis muscle inserted on the lesser tubercle of the bone humerus. As you can see, the subscapularis muscle, which is on the anterior side, is inserted on the lesser tubercle, whereas the sit muscle, which are posterior superior, coming from scapula bone, inserted on the greater tubercle. The sits muscle are the one which make the rotator cuff, and the rotator cuff is more strong on the posterior superior aspect and weak anteriorly. Subscapularis is also called as the forgotten muscle of the rotator cuff, and when it comes to shoulder dislocation, it is observed since there is more muscle posterior superiorly, so the shoulder joint is more strengthened there. The dislocation of shoulder joint are more seen anterior inferiorly, as it is weak anteriorly. Only one muscle is there, subscapularis, and inferiorly it is deficient altogether. When we describe the axilla, it is a pyramid-shaped area which is having the anterior wall, posterior wall, lateral wall, and the medial wall. There's a base, and then there is an apex also. Let us look at the anterior wall, which is basically the pectoralis major and the pectoralis minor on the cover of that. If you're talking about the posterior wall, there will be subscapularis muscle along with the latissimus dorsi and the teres major. When it comes to the lateral wall, it is the humerus bone, and when it comes to the medial wall, it is the upper four ribs along with the origin of serratus anterior muscle. And it will contain the axillary artery vein and also the brachial plexus there, which is entering the axilla region from the neck region. So as we said, the anteriorly we will have pectoralis major minor, and the posteriorly will have the subscapularis muscle. Along with that, you also have teres major and latissimus dorsi. Medially, you have the upper four ribs taking origin from there is serratus anterior, and laterally is the bone, which is the humerus bone. We want to take a transverse section here, and we will find that anteriorly there is no bone, but posteriorly is the scapular bone, and laterally is humeral bone, and the medially is the ribs there. So as we have taken this transverse section, we want to talk about the lateral bone, which is the humerus bone, and when it comes to the posterior bone, that will be the scapular bone, and when it comes to the medial bone, then it is the ribs. Ribs are giving origin to serratus anterior muscle, which will be inserted on the anterior aspect of the scapula, on the medial border of the scapula. And when it comes to to the pectoralis major muscle, it is taking origin from the costal cartilages inserted on the lateral lip of the bicipital groove. In the bicipital groove, you have the long head of the biceps tendon, and at the floor is the latissimus dorsi. Along with that comes the teres major from the posterior side. So it is the lady between two major. One major is attaching to the lateral lip of bicipital groove, the pectoralis major, and one major is inserted on the medial lip of bicipital groove, that is teres major, which is coming from the dorsal aspect of the scapula, lateral border of the scapula, whereas the lady came from the lower back. And when it comes to subscapularis muscle, which is coming from the anterior aspect of the scapula, that is the origin, insertion will be lesser tubercle on the bone humerus. These three muscles are the posterior wall of axilla, that is subscapularis, latissimus dorsi, teres major, three muscles posteriorly wall of axilla, and two muscles anterior wall of axilla, pectoralis major minor, and one muscle medial wall of axilla, which is the serratus anterior muscle. When it comes to the content, you will find there's an axillary sheath along in that there will be the axillary artery, and there are three cords of brachial plexus. If it comes to the posterior cord, it is lying behind the axillary artery. Lateral cord is lateral to the axillary artery. Lateral cord continue as the musculocutaneous nerve, whereas the posterior cord continue as the radial nerve. When it comes to medial cord, it will be continuing as the ulnar nerve. The axillary vein is medial and outside the axillary sheath. These are the contents of the axilla. Now we talk about some of the scapular spaces. Looking at the dorsum of the right scapula, you can see there's a quadrangular space, upper triangular space, and lower triangular space. When it comes to the quadrangular space, you'll find that there is the teres minor muscle taking its origin from the dorsum of the scapula, the lateral border, and inserted on the greater tubercle of the bone humerus, whereas the teres major taking origin from the lateral border of scapula, dorsum of scapula, and inserted on the anterior humerus, the medial lip of the bicipital groove. When it comes to long head of triceps, it takes origin from the infraglenoid tubercle inserted on the ulnar bone down there. This is the shaft of the bone humerus then. Now, quadrangular space is basically bounded by the teres minor superiorly and the teres major inferiorly, and medially is the long head of triceps, and laterally is the surgical neck of the humerus. The content are the axillary nerve, which is coming from quadrangular space to the surgical neck of humerus, along with the artery which is running posterior to the humerus, around the humerus, and it is called posterior circumflex humeral artery. It is a branch of the third part of the axillary artery and will be anastomosing here with the anterior circumflex humeral artery coming from the anterior side. Axillary nerve is going to supply the deltoid muscle and also the teres minor muscle here. If there's a fractured surgical neck of humerus, then there will be paralysis of the deltoid muscle and the teres minor muscle. When it comes to the lower triangular space, you'll find that we have the boundary by the teres major muscle superiorly, and medially it is the long head of the triceps, and laterally it is the shaft of the humerus, and then you find the content are radial nerve passing the lower triangular space towards the radial groove, which is behind the bone humerus, mid-shaft humerus. Along with that is coming the deep artery of arm, which is called profunda brachial artery, and if there's a fracture mid-shaft of humerus, then the radial nerve will be damaged in the lower part of the radial groove. You can also see there is an upper triangular space where you have the circumflex scapular artery going around the bone scapula. It is coming from the third part of the axillary artery, the circumflex scapular artery, participating in scapular anastomosis, a content of the upper triangular space. Presently, we are looking at the lower end of the right humerus, and you can see there is the condyles of the humerus. Lateral condyle is the capitulum related with the radius bone laterally, and medial condyle is the trochlea, which is related with the ulnar bone medially, and these structures are intracapsular. This green color is the capsule attachment here, and the condyles are intracapsular. They are pressure epiphyses for the transmission of the weight, whereas if you say epicondyles, they are traction epiphyses. They are extracapsular and they are produced by the pull of some bones. If you're talking about the medial epicondyle, there is the common origin of the anterior forearm muscle, and they are pulling here, causing traction epiphyses, which is extracapsular. If it is inflamed due to pull of these muscle, then it is we say medial epicondylitis, which is golfer's elbow. When it comes to the lateral epicondylitis, which is actually the origin of the extensor muscles, posterior forearm muscle, common extensor origin, that could be the tennis elbow, lateral epicondylitis. Talking about the cubital fossa, you will see it is present in front of the elbow joint, a triangular space, and bounded by a lateral muscle which is called brachioradialis muscle, taking its origin from the lower end of the humerus, that is the lateral supracondylar line, and inserted on the radial tuberosity down there near the wrist joint. So that is the origin which is evident here. Medially is pronator teres muscle, which is taking origin from the common flexure region, which is the anterior aspect of the medial epicondyle, and then inserted on the radius bone laterally. Now, the base of the triangular space, cubital fossa, is the imaginary line connecting the two epicondyle. As it comes to the floor, there will be some muscles like supinator muscle is at the floor, and when it comes to the roof, there will be skin along with the bicipital aponeurosis, which is the insertion of the biceps muscle. Now, when it comes to the content, you can find that there are two nerves. One is lateral, which is the radial nerve. One is medial, which is the median nerve. And between the two nerves, you will find there are two more structures. When it comes to the radial nerve, it is coming in front of the lateral epicondyle and divided into two branches. One is motor and one is cutaneous branch. And when it comes to the median nerve is going to pass between the two heads of the pronator teres muscle there. Can be compressed in the pronator teres syndrome. Now, the other two things are, you can see the tendon of the biceps brachii muscle, content of the cubital fossa to be inserted on the radial tuberosity bone radius, and also giving the bicipital aponeurosis at the roof of the cubital fossa. And then there is a brachial artery, content of the cubital fossa, giving two arteries, one going with the radius bone, radial artery, one going with ulnar bone, the ulnar artery. All the three arteries are content of the cubital fossa. Now we want to talk about the muscles of the anterior forearm, and we will find that there are 5 superficial muscles, and then there are 3 deep muscles as well. When it comes to 5 superficial muscles, they will be actually lateral to medial. You can say there is a pronator teres muscle, which we'll see a diagram, and then there is a flexor carpus radialis, and then there is the palmaris longus muscle, and then flexor digitorum superficial, and then there will be flexor carpus ulnaris. That we will see in a diagram which is coming up. Deeper muscles are 3 of them. They are called as flexor digitorum profundus, which is a counterpart of FDS because this is superficial, that is a deeper muscle. Then you will also have there is a flexor pollicis longus for flexing the thumb, and then there is a deep muscle pronator quadratus. Let us first look at the superficial 5 muscles now. As you will see, they are coming from the medial epicondyle, the anterior aspect, which is common flexor region. The very first muscle we talk about is pronator teres muscle, which is taking origin from the common flexor region, which is the anterior aspect of the medial epicondyle. That is, the origin insertion is on the radius bone laterally, and if you remember, that was forming the boundary of the cubital fossa here, and is going to turn the radius for pronation. Number 2 muscle is the flexor carpus radialis, attaching to the metacarpal bones here, and it is coming from the radial side, so it can flex the carpus from the radial side. It can also do radial deviation. Then the muscle number 3 is palmaris longus, which is coming here, inserted on the anterior aspect of the flexor retinaculum and giving the palmar aponeurosis on the hand. Number 4, flexor digitorum superficialis muscle, which is for the forefingers, flexing the forefingers. And then the 5th muscle is flexor carpus ulnaris towards the ulnar bone, having a pisiform bone, which is a sesamoid bone, and then it can cause flexion of the carpus, and it can also cause ulnar deviation. If you are working with the flexor carpus ulnaris for ulnar deviation and the flexor carpus radialis for radial deviation, then both of them will be cancelling each other, and then there will be a total flexion of the carpus, this joint. So these are the 5 superficial muscles. Let us remove them and look at the 3 deep muscle as well. Here you can see the 3 deep muscles. One of them is the flexor pollicis longus to flex the thumb, and then there is a flexor digitorum profundus to flex the finger. Basically, it is inserted to the distal phalanx, so it can cause distal interphalangeal flexion there. And then you also have pronator quadratus muscle, which is turning the radius, so for pronation. So as we were talking about the movements, there are the muscles which can cause the flexion of the wrist joint, and their names are flexor muscles, flexor carpus ulnaris, flexor carpus radialis, or flexor digitorum superficial, or FDP. Also, palmaris longus means whatever muscles they are crossing here can fold the wrist joint. When it comes to the radial deviation, then it will be flexor carpus radialis. When it comes to ulnar deviation, then it will be flexor carpus ulnaris. When it comes to pronation, you have pronator teres, the social muscle, pronator quadratus, which is a deep muscle. But when it comes to supination, then you should remember biceps brachiae is a powerful supinator, and there's a supinator muscle at the floor of the cubital fossa. There are two supinators and there are two pronators. Then when it comes to the dorsiflexion or extension of the wrist, then you have to talk about forearm muscle separately. Now we are talking about the nerve supplied to the anterior forearm muscle and the hand muscle, and there are two of them. One is the median nerve and the ulnar nerve. When it comes to anterior forearm muscle, most of them are supplied by the median nerve and the deep branch called anterior interosseous nerve, though the 1.5 muscle out of the 8 muscle will be under the ulnar nerve in the anterior forearm. So 1.5 under ulnar nerve and 6.5 under the median nerve in the anterior forearm. When it comes to the hand, you will find there are 20 muscles almost in the hand, and most of them supplied by ulnar nerve, though few of them, especially the thumb side muscles, are supplied by median nerve. So median nerve is the major nerve in the anterior forearm and the ulnar nerve is the major nerve in the hand. Now the thing is that if I could memorize whatever the ulnar nerve is supplying, then whatever left will obviously be supplied by median nerve. Then I am not bothered that what the median nerve is supplying, because I have to remember one of them. But be careful about this trick when you are using, because there are some muscles which can be having double supply, hybrid muscles. For example, medial half of flexor digitorum profundus supplied by the ulnar nerve, and the lateral half of the FDP is supplied by the median nerve. Also, the lateral half of the FDP, which is supplied by median nerve, is giving the two lumbricals, and they are supplied by median nerve. Whereas when you are talking about the medial half of FDP for these two fingers, flexing the finger, then you can also see the lumbrical for these fingers are also supplied by the ulnar nerve. Otherwise, we can just understand that we are going to focus only on ulnar nerve and memorizing the muscle supplied by it. As we have told that in the anterior forearm, there are 5 superficial and 3 muscle deep, which is total 8. Out of 8, only 1.5 supplied by ulnar nerve. That is the middle half of FDP and the flexor carpus ulnaris. Otherwise, all the 6.5 muscle in the anterior forearm will be supplied by median nerve, and its deep branch called anterior interosseous nerve. But when it comes to hand, almost all the muscles are supplied by the ulnar nerve, except some of them which are towards the thumb side. So what is ulnar nerve supplying? Ulnar nerve supplying the hypothenar muscle for the little finger there, and it is also supplying a subcutaneous muscle, palmaris brevis over hypothenar eminence. And when it comes to interossei, maybe forepalmar, foredorsa interossei, they are deep muscles, so supplied by deep branch of ulnar nerve, and also one deep muscle of the thumb, which is called ADD, adductor pollicis, supplied by ulnar nerve only. And beyond that, whatever the forearm muscle or hand muscles are, they will be all supplied by median nerve. Let us look at the cutaneous supply as well. If you are looking at the 3.5 fingers anteriorly and the palm region towards the lateral side, that is the median nerve, which is also encroaching upon the nail beds posteriorly, 3.5 fingers. Otherwise, dorsum of the hand is under the radial nerve, but minus the nail beds, because already supplied by median nerve. When it comes to the 1.5 finger dorsum, 1.5 finger ventral, it is the ulnar nerve on either side. The cutaneous supply for the skin of the hand. As we talk about the radial nerve, which is continuation of the posterior quarter of the brachial plexus, given in the axilla, go in the lower triangular space, and then comes in the radial groove behind the bone humerus, and then it comes in front of the lateral epicondyle, give two terminal branches in the cubital fossa. One is cutaneous to supply dorsum of the hand, 3.5 finger, but minus the nail bed, and the motor nerve is supplying posterior forearm muscle, which is posterior interosseous nerve. Understand, when the radial nerve is passing in the axilla and in the radial groove, it will supply the muscle triceps for elbow extension. It is also supplying a small muscle enconeus in the radial groove for elbow extension. And when it comes out of the radial groove, supply some muscles like the extensor carpus radial longus, powerful wrist extensor, and also brachioradialis muscle. The muscles are taking origin from lateral supracondylar ridge there. And then there are some muscles which is coming from the common extensor origin. They are the forearm muscle here, including the ECRB, and most of them are extensors. So extensor carpus radialis brevis, and then there is extensor of the thumb pollicis, extensor of the digit or extensor of the index finger, extensor of the little finger. Mostly they are extensors supplied by posterior interosseous nerve. What will happen if I have injury of the posterior interosseous nerve? Then there will be difficulty of the metacarpophalangeal extension. And what if I have injury of the radial nerve below the radial groove, in the lower part of the radial groove? Then the ECRL muscle will be paralyzed and there will be difficulty in the wrist extension. And what if I have injury of the radial nerve in the axilla itself, like crutch palsy? Then you will find that there is also loss of the elbow extension because there is paralysis of triceps muscle. Then, as we are talking about the posterior forearm muscle, we are supposed to see that the lateral supracornular line is giving muscles like the brachioradialis and ECRL, which were supplied directly by the main trunk of the radial nerve, whereas the posterior interosseous nerve, the branch of the radial nerve, is supplying the muscle coming from the common extensor region, which is lateral epicondyle, involved in the tennis elbow. Muscles which are coming from there are mostly extensor of the digits, that is extensor digitorum or extensor digiti minimi or extensor indicis. There are also extensor carpus radial, longus and brevis muscle, and then you will see there are some deeper muscles which are working on the thumb. There is abductor pollicis longus, and then there are two extensors. One is called extensor pollicis longus and one is extensor pollicis brevis. They are the one which will be forming boundaries of anatomical snuff box. Then understand that at the lower end of the radius bone there is a Lister tubercle, and the extensor pollicis longus is coming medial to that, and the extensor pollicis brevis is coming lateral to that. As the extensor pollicis brevis come lateral to that, it is followed by abductor pollicis longus, and both of them will be forming anterolateral boundary of anatomical subbox, whereas the extensor pollicis longus is going to form posteromedial boundary of anatomical subbox. This is the anatomical subbox. As I suggested, there are some posterior forearm muscles coming here. Extensor pollicis longus, which is coming medial to the dorsal tubercle of Lister on the radius bone, is forming the posteromedial boundary of anatomical subbox, whereas the anterolateral boundary are the two tendons, but the first name should always be extensor pollicis brevis. Additionally, you have the abductor pollicis longus. These two can be inflamed in the Quervain tenosynovitis, where anterolateral boundary of anatomical subbox which has become painful, and the Finkelstein test, which is sudden ulnar deviation, these two tendons will be very painful. As you can see, the two tendons which are anterolateral, they are extensor pollicis brevis and abductor pollicis longus, and then the posteromedial tendon is the extensor pollicis longus. And then you see there is the radial artery, which is the content of the anatomical subbox. You can take a pulse of the artery, and you have to compress the artery against the bone, which is called scaphoid bone. Scaphoid bone is at the floor of the anatomical subbox, and if it is fractured, there will be tenderness in the anatomical subbox. The four bones which are at the floor of anatomical subbox are the lower end of the radius styloid process, then scaphoid, then trapezium, and the base of the first metacarpal. So four bones at the floor. The roof is skin with the nerve and a vein. The nerve is the social cutaneous branch of the radial nerve supplying dorsum of the hand, 3.5 finger minus the nail bed, and there is a vein running at the roof of anatomical subbox along with this nerve, which is cephalic vein, which is the lateral continuation of the dorsal venous arch on the hand. In the Quervain tenosynovitis, when we do the Finkelstein test, which is sudden ulnar deviation, we'll find that the tendons of the abductor pollicis longus and extensor pollicis brevis have been inflamed, and it will be a painful maneuver to the patient. These tendons form the anterolateral boundary of anatomical subbox, which have become involved in inflammation. Here we are looking at the comparative analysis of the three major nerve injuries seen in the upper limb. This is the median nerve injury, which can present as the hand of benediction if it is a high median nerve injury. There could be the ulnar nerve injury, which is presenting with the claw hand deformity, and this is the radial nerve injury presenting with the wrist drop and finger drop. Let us look at them in a sequence now, starting with the median nerve injury. It is the hand of benediction in the median nerve injury, plus you can see that 3.5 fingers have sensory loss, including the nail bed as well, the territory of median nerve. Now, what is hand of benediction? We are asking the patient to make a fist, but the patient is unable to do that, and these three fingers are lagging behind. They are unable to fold. Why they are unable to fold? Because there is flexor pollicis longus, which is going to fold. The thumb is supplied by anterior interosseous nerve, branch of median nerve. If there's a median nerve injury somewhere above the elbow, then the anterior interosseous nerve is not working and the finger is unable to fold. Similarly, these two fingers, they are folding with the help of flexor digitorum superficial lumbrical and flexor digitorum profundus. But the flexor digitorum profundus, which work on these two fingers, are supplied by anterior-interosseous nerve. So if median nerve is injured, its branch anterior-interosseous nerve not working, then he may not be able to fold them properly. Then how come these fingers are folding? Because these fingers are folded by the flexor digitorum profundus, which is the medial half supplied by the ulnar nerve. So ulnar nerve is still working. Whenever the patient try to make a fist, these two fingers can fold because ulnar nerve is working, but they are lagging behind because median nerve is not working. That is called as hand of benediction. In claw hand, which is specifically shown here for ulnar nerve, actually claw hand occurs because the lumbricals and interossei are not working, and most of the muscles which we are talking about, all of the interossei and the two lumbricals are supplied by ulnar nerve. If ulnar nerve is not working, there will be a difficulty of MCP flexion and interphalangeal extension. In fact, the forearm muscles will become more powerful, and you will find that the anterior forearm muscle, which is flexor digitorum profundus, is causing the folding of the IP joint, whereas the extensor digitorum is causing MCP hyperextension. So that is what is called as claw hand deformity here, seen in ulnar nerve injuries. Plus, there will be some sensory loss on 1.5 fingers, maybe on the dorsal or on the anterior aspect of the hand. As you can see, we have already mentioned that the interphalangeal flexion was due to unopposed flexor digitorum profundus on the anterior side, and there was a hyperextension of MCP because of extensor digitorum becoming more powerful because it is unopposed here. Ulnar nerve injuries. Now let us talk about ulnar paradox also. Ulnar paradox is telling that if there is a high ulnar nerve injury, there will be less of the claw hand, and if it is low ulnar nerve injury, there will be more of claw hand. You know why there is a claw hand? Because there is FDP muscle pulling the fingers, and if you have the ulnar nerve injury somewhere at the wrist, then the flexor digitorum profundus is going to pull the fingers and causing the clawing. But if we have high ulnar nerve injury somewhere here, then even the FDP will be paralyzed, and because FDP is paralyzed, it cannot pull the fingers here, so there will be less claw hand. So high ulnar nerve injury and less claw hand due to paralysis of the FDP muscle simultaneously is called ulnar paradox. Normally, what we expect is if a nerve is damaged higher, there should be more problem. If a nerve is injured lower, there will be less problem. But here in this case, when the nerve is injured high, you have less problem, and that is what we call paradox. Talking about the radial nerve injury, we'll find that dorsum of the hand will have sensory loss, but the nail beds will be still functional in cutaneous territory because that is the territory of the median nerve. Plus, there will be a finger drop at MCP joint. MCP joint cannot cause MCP extension, and there will also be a wrist drop. There is inability to do dorsiflexion at the wrist, but the interphalangeal joints can still do extension. How the interphalangeal extension is possible? Because that is also possible because of the lumbrical interossei supplied by the median and ulnar nerve. In fact, lumbrical interossei they insert on the dorsal distal expansion and cause interphalangeal extension, even in case there was some radial nerve injury. So basically, the problem is at wrist extension and MCP extension. As such, the IP extension is still possible. Now, let us look at some details of the carpal bones, which are 8 in number and 4 in the proximal row, 4 in the distal row. And we can remember by a mnemonic, which is she looks too pretty, try to catch her. It is the scaphoid, then lunate, triquetrum, and pisiform bone, the smallest of all, and then trapezium, trapezoid, capitate, and hamate. The largest bone is the capitate bone here. Let us magnify this area. So as I'm suggesting that capitate bone is the largest of all the carpal bones, and it is also the central bone there, and it is the oldest bone there. How do you say that? Because it is the first bone to start ossification. Understand, when a baby is born, there are no carpal bones as such. There is hyaline cartilage which is going to undergo endochondral ossification after birth. So the first bone to start ossification is the capitate bone. So once again, we can look at the proximal row. This is the scaphoid, lunate, triquetrum, and pisiform. Then you have the trapezium, trapezoid, capitate, and the hamate. As I'm suggesting, hamate is the central bone, the largest of all, and the oldest of all. The first to start ossification, it is the second month after birth of the baby in question. Then the next bone to start ossification is on the side only, the hamate, which is third month after birth of the baby. And then comes the third ear, which is the triquetrum, fourth ear, which is the lunate, and fifth ear, which is the scaphoid. Actually, in a sequence, you will then say trapezium and trapezoid. The last bone to start ossification is the pisiform, which is 9 to 12 years after birth. You can see it is like an inner circle going out. See, you start here, that is the capitate, then you have the hamate, then you have the triquetrum, lunate, scaphoid, trapezium, trapezoid, and then you jump on to pisiform bone. It's like a circle jumping on back to the pisiform bone. 9 to 12 years after birth is the date of ossification. Looking at the wrist joint, which is also called radiocarpal joint, it will be between the lower end of the radius and the carpal bones, namely scaphoid, lunate, and triquetrum. The ulnar bone is not participating in the wrist joint as it is separated by a fibrocartilaginous articular disc there. And this wrist joint is considered as ellipsoid synovial joint, though some books can also mention it as condylar synovial joint. When it comes to the first carpo-metacarpal joint, which is between trapezium bone and the base of the first metacarpal, it is the joint which is a saddle synovial joint for the movement of thumb position, counting the fingers. Saddle synovial joint. As we talk about the carpal tunnel syndrome, there are 8 carpal bones and they are covered by the flexor reticulum, creating a tunnel here. And the carpal bones where the flexor reticulum attaching is the scaphoid bone, for example, and the pisiform bone on the other side. Now, the tendons which are passing under this flexor reticulum are 4 tendon of flexor digitorum superficial, 4 tendon of flexor digitorum profundus to fold the fingers, and there is 1 tendon of flexor pollicis longus to fold the thumb. Now, 4 plus 4 plus 1, it is the total 9 flexor tendons passing under the flexor reticulum, and they can be inflamed, swollen, compressing the median nerve in carpal tunnel syndrome. It is a case of repeat stress injury, some data entry operator continuously working on the keyboard, and overuse of FDS, FTP, and FPL that is leading to their inflammation, swelling, and compressing the median nerve, which is going to present with some sensory motor loss. In this case of carpal tunnel syndrome, there is no problem with the ulnar nerve as such because ulnar nerve passes superficial to the flexor reticulum. The tendon which passes superficial to flexor reticulum is also the palmaris longus, which was actually fused with the flexor reticulum superficially. As the carpal tunnel syndrome patient has compression of median nerve in the carpal tunnel, there will be tingling sensation at 3.5 fingers, including the nail bed. But be careful, there is no sensory loss on the palm. Why? Because palmar cutaneous branch is already given before the nerve was passing under the flexor reticulum. Since the palmar cutaneous branch is already given before flexor reticulum, it is the sensory area which is still functional. But since the nerve is compressed in the carpal tunnel, only the skin on the fingers and thumb, which is 3.5 fingers, will be involved, sparing the skin on the palm as such. And in carpal tunnel syndrome, when median nerve is injured, you will find that there is thenar atrophy because most of the thumb muscle depend upon the median nerve. If the median nerve has been compressed, then there will be thenar atrophy. Plus, the thumb will remain in ADD, adduction deformity, because adductor pollicis is supplied by ulnar nerve, which is still working. This patient will have the pen test positive, means there is inability to do anterior abduction of thumb as the adductor pollicis brevis muscle supplied by median nerve is not working, and the thumb will remain in ADD, adduction deformity. These patients can't even do thumb apposition because in thumb apposition, what is the requirement is the first movement, anterior abduction of thumb, which is not happening in the patient. So we call it as loss of thumb apposition, thenar atrophy, and ape hand deformity, which is thumb remains in ADD, adduction deformity. When it comes to ulnar nerve, which is running towards the ulnar side of the hand, you will find that it is passing through a tunnel which is called as Guyon's canal. Actually, it is passing superficial to the flexor reticulum, but deep to a ligament which is called as the palmar carpal ligament, which we will see in the next diagram. And when the ulnar nerve is passing here, it will be running lateral to the pisiform bone and then medial to the hook of the hamate. And in this tunnel, it is giving 2 branches. One is deep and one is the superficial branch. As we have taken a section section here in the hand, we can understand this pink color is the flexor retinaculum, and deep to flexor retinaculum you will find this is the median nerve. But as you see, ulnar nerve is passing superficial to flexor retinaculum, though it is covered by what is called as the palmar carpal ligament. This is a tunnel which is called as the Guyon's canal, and in that not only ulnar nerve is there, but also ulnar artery is passing. Sometimes the compression of the median nerve in carpal tunnel syndrome is seen, but it will not involve the ulnar nerve. Ulnar nerve can be involved in Guyon's canal syndrome, can be seen in the cyclist, which we will see a diagram now. Here is the underbar which can be compressing on the ulnar side of the hand. In the Guyon's canal, the ulnar nerve is compromised, and then there could be sensory loss in 1.5 finger anteriorly here, and some of the muscle may also get compromised due to that compression of ulnar nerve chronically over the handlebar of a cycle. As we discuss the muscles in the hand, there are about 20 muscles, and some of them are towards the thumb, thenar muscle, some are towards the little finger, hypothenar muscle. Then there are 4 lumbricals which will be coming from the tendons of the flexor digitorum profundus, which is attaching to the base of the distal phalanx, and then there are 4 palmar interossei and 4 dorsal interossei. You will see that the thenar muscles have the same name almost as the hypothenar muscle. The difference is thenar are working on the thumb, so pollicis muscle, and the hypothenar are working on little finger, so digiti minimi muscle. So the names will be like a flexor for the pollex, and abductor for the pollex, and then apponens for the pollex. Similarly, you have the flexor, abductor, and apponens digiti minimi muscle there. Now understand that when we are talking about ADD adductor pollicis, which is quite a deep muscle, it is a muscle working on the thumb, but is not a thenar muscle. It has a separate supply as compared with the thenar muscle. Thenar muscle usually median nerve, but ADD adductor pollicis, which is not a thenar muscle, supplied by a different nerve, that is ulnar nerve. How do you identify the lumbricals? They are actually coming from the tendon of flexor digitorum profundus, 4 tendons of 4 lumbrical, and they come lateral to the tendon of flexor digitorum profundus. The first 2 are unipinnate lumbricals, and the next 2 are bipinnate lumbricals, and they'll be supplied by ulnar nerve. They are on the ulnar side, and these 2 lumbricals will be supplied by median nerve, as they are coming from the flexor digitorum profundus lateral half of FDP, supplied by median nerve. So let us focus upon the lumbricals in more detail. As you see, these are the tendons of FDP attaching to the base of the distal phalanx for the interphalangeal flexion at the DIP. They are giving the lumbricals laterally, and laterally. They are going to flex the metacarpophalangeal joint, and they are also going dorsal to insert on the dorsal distal expansion, helping extensor digitorum muscle for the interphalangeal extension. And the first 2 lumbricals are unipinnate, and the next 2 lumbricals are bipinnate, so they'll be more powerful. They are supplied by ulnar nerve, whereas these 2 are supplied by median nerve. As I said, lumbricals are working with interossei to do 2 functions. One is flexion of MCP, other is interphalangeal extension. Let us talk about the interossei as well. As we talk about the interossei, there is a mnemonic PAD and DAP. Palmar for adduction, adding the finger, and dorsal for abduction or spreading the finger. So middle finger is the axis, and which is where you are going to use the muscle. If you want to spread the finger, then you will be using the dorsal interossei for abduction, taking the finger away from the axis, and if you are adding the finger, palmar for adduction. Actually, you will find that middle finger will have no palmar interossei because it is already in adduction. So only the lateral fingers will need the palmar interossei. Whereas if you are talking about abduction, then the middle finger may be moving towards the thumb, that is abduction, or towards the little finger, that is also abduction. So there are 2 dorsal interossei on the middle finger for abduction, moving away from the axis, which is the middle finger itself. So as we understand, dorsal are for abduction of the finger, which is taking the fingers away from the middle finger, the axis there. The dorsal interossei on the middle finger will be 2 in number. As you move the middle finger towards the thumb side, it is using the dorsal interossei here. If you move the middle finger towards the little finger side, then you are using dorsal interossei here. So 2 dorsal interossei on the middle finger, otherwise you have 2 more for the other fingers to spread the fingers. And you can see all the dorsal interossei are bipinnate, but palmar interossei interosseae are only unipinnate. Plus, you see, they are for adding the finger. So you have to add the finger toward the middle finger, which is always in adduction. So the middle finger will require no palmar interosseae as such, because only the other fingers have to move towards the middle finger. If you want to check for the palmar interosseae, you can do what is called as card test. Take a card and tell the patient to hold the card between the finger. That will require adding a finger, and that is for palmar interosseae. If you want to check for the dorsal interosseae, then just ask the patient to spread the finger, and you are preventing that spreading by putting some resistance here. This is for dorsal interosseae testing. During development, we will find that the main artery, the axis artery for the upper limb, is called as the anterior interosseous artery, whereas there is a preaxial artery as well as postaxial artery. The radial artery, the radial bone, is the preaxial bone and preaxial artery, whereas the ulnar bone and the ulnar artery are postaxial structures. Similarly, you'll find a vein which is running towards the thumb side radius bone. Cephalic vein is the preaxial vein, whereas the vein which is running at the base of the forearm with the ulnar bone, ulnar artery, the basilic artery, is postaxial vein. So radial artery and the cephalic vein are the preaxial structures along with the radius bone, whereas the ulnar bone and the ulnar artery and the basilic vein are the postaxial structures. Now let us look at the details of the upper limb arteries. As you see that in the neck region there is a subclavian artery which will be crossing outer border of first rib to enter the axilla, become the axillary artery, which crosses lower border of teres major to enter the arm, become brachial artery, which enters the cubital fossa, giving two branches there, following the radius bone radial artery, ulnar bone the ulnar artery. So there are three arteries in the cubital fossa. The radial artery will be entering the palm to form the deep palmar arch, and the ulnar artery will be entering the palm to form social palmar arch, and they will have anastomosis here in the palm. If you want to check the anastomosis, you can do Allen test. Allen test is done before you take a radial artery blood sample. Maybe you were taking a radial artery blood gas analysis, and you have to make sure that ulnar artery give enough blood around the anastomosis here and reaches the territory of the radial artery as well, in case there is a radial artery thrombus. And due to that blood sampling procedure, the thumb should not die of ischemia. You have to check for the patency of ulnar artery capable of supplying the thumb, and that is called as Allen test there. Now we want to look at the axillary artery details. Let us zoom this area then. As the subclavian artery crosses the outer border of first rib, it will enter the axilla to become axillary artery till the lower border of teres major. It is axillary artery. It is covered by a muscle, pectoralis minor muscle, dividing the artery into three parts: proximal to the muscle, deep to the muscle, and distal to the muscle. The first part, which is proximal to the muscle, will be giving a branch which is called superior thoracic artery, which is going to supply the mammary gland. Remember, it is not participating in scapular anastomosis. The second part of the axillary artery, under cover of the pectoralis minor, will be giving two branches, and they are called as the thoracoacromial artery and lateral thoracic artery. Lateral thoracic artery is going to supply the mammary gland. The third part of the axillary artery, which is distal to the pectoralis minor muscle, will be giving three branches. There is anterior circumflexural artery and posterior circumflexural artery. They are anastomosing on the surgical neck of the humerus. The third branch for the third part of axillary artery is under the scapula, called subscapular artery, participating in scapular anastomosis and also supplying the mammary gland. The mammary gland is a highly vascular structure. As you can see, it is supplied by many thoracic artery, namely the internal thoracic, the acromiothoracic, the superior thoracic, the lateral thoracic. As you can see, the first part of the subclavian artery will be giving the internal thoracic artery, which is parasternally running and supplying the medial aspect of the mammary gland. Then comes the axillary artery, and first part giving superior thoracic artery, supplying the mammary gland. Then the second part is giving the acromiothoracic and the lateral thoracic, supplying the mammary gland. And then you will find that third part will be giving subscapular artery, supplying the mammary gland. Mammary gland is also supplied by the posterior intercostal arteries, branches of the descending thoracic aorta. So it's a highly vascular structure as such. And knowing about the arteries will helpful for us to know the veins, and the veins will have almost same name. And when you know the veins, then you can also discuss the lymphatics, because there's a rule: lymphatic follow vein follow artery. If you know the artery, you know the veins, and if you know the veins, then you know the lymphatics as well. As we talk about the scapular anastomosis, it may be happening sometime like there's a cervical rift compressing the subclavian artery and upper limb is suffering from ischemia. To supply that ischemic zone, you will have anastomosis between branches of the axillary artery and branches of the subclavian artery, which can bypass the block and supply the ischemic zone. Now here, you are looking at the dorsum of the right scapula, there will be some artery. That is the subclavian artery running in the neck region. We are looking at that from the dorsal view. As it will cross the outer border of first rib, enter the axilla, it will become the axillary artery. So here it is becoming the axillary artery here. And there was a block in the subclavian artery leading to upper limb ischemia, maybe due to some cervical rib. Now, since you have to supply upper limb ischemia zone, you will see the branches of the axillary artery and anastomosing with branches of the subclavian artery. So here is the branch of axillary artery, and that is the branches of the subclavian artery making the scapular anastomosis. Remember 4 names here. The branches of axillary artery are subscapular and circumflex scapular artery, and branches of subclavian are the dorsal scapular artery and the suprascapular artery making the scapular anastomosis. Let us look at them here as well. So here you can make out the third part of the axillary artery is giving us one artery under the scapula called subscapular artery, and subscapular artery itself is giving circumflex scapular artery around the scapula. And after giving circumflex scapular artery, this subscapular artery will continue downward as a thoracodorsal artery, and this thoracodorsal artery is going to anastomose with the dorsal scapular artery coming from the subclavian artery. Here you can see the subclavian artery running in the neck region. We are looking from the dorsum of the neck here. Now this subclavian artery first part is giving some branches like the thyrocervical trunk, and the thyrocervical trunk is giving branches like here suprascapular artery, and suprascapular artery is going to anastomose with the circumflex scapular artery, so that the blood from the first part of the subclavian artery can come into the thyrocervical trunk, into suprascapular artery, and anastomose with the circumflex scapular artery, then come into the subscapular artery and supply the upper limb axillary artery in case there was a block in the distal part of subclavian artery due to cervical rib. There is one more channel through which you can send the blood of the subclavian into the axillary artery. What is that? As is understood, the first part of subclavian is giving us the transverse cervical artery, and the deep branch of the transverse cervical artery can sometimes give us the dorsal scapular artery, and this dorsal scapular artery is anastomosing with the thoracodorsal artery there. So there was a cervical rift compressing the subclavian artery, and you have no chance of sending blood further from here, so blood will be pushed back into the subclavian artery. As the blood is going into first part of subclavian, it will push into the thyrocervical trunk, into the transverse cervical artery, and the deep branch, which is dorsal scapular artery, which is now anastomosing with the thoracodorsal artery, which is then sending blood into the subscapular artery and axillary artery. You can continue supplying the upper limb ischemia zone. So basically, the 2 anastomoses are there. One is the thoracodorsal artery and the dorsal scapular artery, and the other is the suprascapular artery and the circumflex scapular artery. Here we are going to talk about the veins of the upper limb now. Since we already know the arteries, it will be easy to follow the veins because they have same name. But this is about the deeper veins. There is another set of superficial veins as well. Before you talk about superficial veins, let us just discuss the deeper veins first. You will notice that there is a radial artery, so there will be a radial vein as well towards the radial bone, and towards the ulnar bone you will have the ulnar artery, and there is this ulnar vein as well. Now they are going to join to form the brachial vein in the arm, and the brachial vein which you see here is going to become continuous with the axillary vein, and the axillary vein itself is going to continue as the subclavian vein in the neck region and then joined by the internal jugular vein. As the internal jugular vein is coming from the head and neck region and joined by subclavian vein which is coming from the upper limb, together they will form the brachiocephalic vein. And the brachiocephalic vein of the right side and the left side, they will be joining to form the superior vena cava, which will be entering the right atrium of the heart. Now that was regarding the deeper veins. Let us look at the superficial veins also, which are dorsal venous arch and laterally cephalic vein and medially the basilic vein. As you will see, there is a dorsal venous arch which is laterally continuing as the cephalic vein, and this cephalic vein is going to enter the axillary vein there. Understand that the cephalic vein, which is a subcutaneous superficial vein, is coming from dorsal venous arch and lies at the roof of anatomical stump box. Before it is going to enter the axillary vein, deeper vein, it has to puncture the clavicle, pectoral fascia, then it will enter into the axillary vein. Now at the base of the forearm you have the basilic vein, and the basilic vein, which is the superficial subcutaneous vein, is going to drain into the brachial vein on the medial side. We should also know that the cephalic vein, some of the blood is shunted towards the basilic vein by what is called as the median cavital vein, and this median cavital vein has the flow superior-medially towards the basilic vein. This median cavital vein, which lies at the roof of the cavital fossa, can be be used for taking intravenous samples like thyroid profile sample, or it can be used for giving blood transfusion as such. Now, knowing the veins will help us to discuss the lymphatic drainage of upper limb as well. Let us take the example of the mammary gland here for lymphatic drainage. Then, to discuss the mammary gland lymphatic drainage, we have to talk about the walls of the axilla as we have learned earlier. Anterior axillary wall is the pectoral wall, which is having some pectoral major muscle, and there will be an artery vein running, which are called as lateral thoracic artery vein. Later to that, anteriorly will be the anterior axillary lymph node or pectoral lymph node, which will be following that lateral thoracic artery and lateral thoracic vein. Whereas on the posterior axillary wall, you have the subscapular muscle, so there will be subscapular artery and subscapular vein, and those lymphatics will be called as the posterior axillary lymphatics or lymph nodes. Laterally, we have the humerus bone, and running is the axillary vein, and there are some lymph nodes, and they'll be called lateral humeral lymph node or lateral axillary lymph node. Now, these three group of lymph nodes will be draining into the central axillary lymph nodes, and central axillary lymph node will be draining towards the apical axillary lymph node, which will be the terminal axillary lymph node, the last axillary lymph node, the apical axillary lymph node. So as you can see that there is the laterally running vein, which is the axillary vein, and along with that there will be some lymph node, and they will be called as the lateral axillary lymph node, which are shown here. Then we have the anterior axillary lymph node, and these anterior axillary lymph node will be running with the lateral thoracic artery and lateral thoracic vein along with the pectoral muscles there. Whereas we have the posterior axillary lymph node also, and they are on the subscapular muscle running with the subscapular artery and subscapular vein. Now these three group of axillary lymph node will be draining to central axillary lymph node, and the central axillary lymph node will be draining towards the apical axillary lymph node, which are lying towards the apex of the axilla. This is the last axillary lymph node or the terminal axillary lymph node. Now where is lymphatic going from here? Let us find out. Now as we suggested, there is anterior axillary lymph node, which are pectoral lymph node, then there is posterior axillary lymph node, which are the subscapular lymph node, and there are lateral axillary lymph node, which are the humeral lymph node. They are all draining in towards the central axillary lymph node, and central axillary lymph node will drain towards the apical axillary lymph node. From there, the lymphatic will go to the supraclavicular lymph node, and from there they are going to the right lymphatic duct if it is on the right side, or thoracic duct on the left side. Now this right lymphatic duct or the thoracic duct will draining into the venous angle, which is called as the jugulo-subclavian venous angle, the meeting point of the subclavian vein and the internal jugular vein, where you have the formation of brachiocephalic vein. So right lymphatic duct will drain to right venous angle, which is right jugulo-subclavian venous angle, whereas the left thoracic duct will draining into the left venous angle, which is left jugulo-subclavian venous angle. Talking about the lymphatic drainage of the mammary gland, it is observed that most of the mammary gland is draining into anterior axillary lymph node, though some of that can go into posterior axillary lymph node also, and as well as the posterior intercostal lymph node. As you see, some of the lymphatics can also move towards the parasternal lymph node, which is internal thoracic artery, internal thoracic vein, and parasternal lymph node, though most of the lymphatics are going towards anterior pectoral axillary lymph node, and from there they'll be going to the central axillary and apical axillary, and then the supraclavicular, and then the right lymphatic duct, because this is the right-sided mammary gland. Some of the lymphatics can also go retrograde fashion, and that will be subperitoneal lymphatics and can fall towards the abdominal viscera like the ovary. If it is falling towards the ovary, you can call it as Kuchenberg's tumor. If the subdermal lymphatics, the cutaneous lymphatics are invaded by the cancerous cells, then there is an appearance called as pue the orange, like the orange peel here, due to the blockage of the subdermal lymphatics. Talking about the spaces in the palm, you will find towards the thumb there is a thenar space, and towards the other fingers medially there is a mid-palmar space. In addition to this thenar space towards the thumb and the mid-palmar space, there are other spaces also, like you have the tenar flexor pollicis longus. Through that comes the synovial sheath, and there is a bursa, which is called as the radial bursa. And towards the little finger, you will have the synovial sheath, which is covering the tendon of flexor digitorum muscles, and that is causing an ulnar bursa. Also understand that any infection of these fingers, they can be moving backward towards the thenar space, like the index finger infection can go to thenar space, but when it comes to the other fingers here, that could be the middle finger or the ring finger, little finger, those infection from the fingers can move on to the mid-palmar space. Actually, these thenar space is continuous with the lumbrical one, and that is why the index finger can send the pus and inflammation towards the thenar space, whereas the lumbrical canal 2, 3, 4, they are connected with the mid-palmar space and these fingers, so any infection from these fingers can lead to the involvement of the mid-palmar space there. As we mentioned during development, the upper limb is going to rotate lateral by 90 degrees so that the thumb will go lateral in anatomical position, whereas the lower limb is rotating medial by 90 degrees so that the great toe will come medial in anatomical position. Upper limb is going to fold anteriorly, so flexor compartment is anterior, whereas the lower limb is going to fold posteriorly, so flexor compartment is posterior for the lower limb. Also understand that there is a lumbosacral enlargement with the root value L1 to S3, and from there comes the root value of the lower limb. Say for example, the sciatic nerve is L45 and S1 to 3, and that is where we have got the other nerves also for the lower limb supply. As you can see here, this is going to be lumbosacral plexus, and where we find that there are nerves like femoral nerve and obturator nerve having the root value L, 2, 3, 4. And along with that, you can also see we have got lumbosacral plexus, which is, as I told you, the L45, S1 to 3 for sciatic nerve. Now we need to understand that sciatic nerve is not a single nerve but two nerves running together. There is the lateral common fibular nerve and there is a medial tibial nerve. Going with the bone tibia is tibial nerve, going with the bone fibula is the fibular nerve. It is called common fibular because further divided into two branches called superficial and deep fibular nerve. When it comes to the pudendal nerve, it is S234, and when it comes to the superior inferior gluteal nerve, we have to find out their root values as well during the discussion. Understand that these nerves are all coming from the lumbosacral plexus in the pelvis region and leaving the pelvis through the greater sciatic notch to reach the gluteal region and continue on the posterior aspect of the thigh. When it comes to root value for the lower limb, it begins with L1 in the inguinal region and reaches the S1 in the little toe. But there is also S2 for the lower limb, which is on the posterior aspect of the lower limb, that is the calf region and the posterior thigh region. S234 becomes the root value of pudendal nerve for the pelvis and perineum. Understand that little toe is always S1 and great toe is always L5, may it be the dorsum of the foot or the sole of the foot. As we look at the muscles of the anterior thigh region, there are two groups, one which is coming from abdomen towards the pelvis, and there is another one which is coming from the thigh to the knee region. There is this psoas major along with the iliopsoas. Together they insert on the lesser trochanter and they are going to flex the hip joint. Chief flexor of the hip joint is iliopsoas, as it is crossing hip joint anteriorly will pull the femur anterior and cause hip flexion. There are some accessory muscles also helping iliopsoas like sartorius muscle crossing hip joint anterior, pectineus muscle crossing hip joint anterior, or rectus femoris muscle crossing hip joint anterior. So three accessory muscles for hip flexion. Now when it comes to rectus femoris, it is a part of quadriceps femoris, so it is also going to cross the knee joint here and pulling the tibia anterior for knee extension. Quadriceps muscles work for knee extension, anterior thigh muscle, whereas there are four hamstring on the posterior thigh which will be working for pulling the tibia posterior, and there will be knee flexion. Now hamstring posteriorly and quadriceps anteriorly will antagonize each other. The medial thigh muscles are basically adductors like adductor brevis, magnus and longus. They pull the femur inside, and that is why they are called as ADD adductors, medial thigh muscles. As you see, muscles of the anterior thigh compartment, I told you there are two groups. One is pectineus, working with the sartorius and rectus femoris for iliopsoas, a chief muscle of hip flexion. Whereas as you talk about the quadriceps femoris, there is one rectus and three vesti. They are pulling tibia anterior for the knee extension, supplied all by the femoral nerve, root value L, 2, 3, 4. And when it comes to the medial thigh, we have mostly ADD adductors, but then we can also have gracilis and obturator externus. Obturator externus they require a special mention here because though they are all supplied by the obturator nerve L234, the obturator externus is not ADD adductor at the hip joint. It is a lateral rotator at the hip joint. Talking about the four hamstring muscles, they take origin from the ischial tuberosity and mostly insert on the bone tibia, though biceps femoris is inserted on the head of the fibula, and they are pulling the bones like tibia posteriorly, so they are the knee flexors. As you can see, this is the ischial tuberosity of the right side posterior view, and you can find that semimembranosus is taking origin from superolateral area, whereas inferiolateral is the adductor longus, posterior part of the adductor magnus. And when you come to the superior and the medial aspect, then it is semitendinosus and long head of biceps femoris taking origin there. These hamstring muscles may be semitendinosus, semimembranosus, or the long head of biceps femoris and posterior part of adductor magnus are all supplied by tibial part of the sciatic nerve, pulling the tibia posterior for knee extension. Understand that short head of biceps femoris is not a hamstring; it is supplied by a separate nerve, which is common peroneal nerve. So, it in a way, biceps femoris becomes a hybrid muscle with the two nerve supply. As we take a transverse section of the right thigh, you will find there are three compartments, as we already mentioned. Anteriorly, we have the quadriceps femoris, one rectus, and three vasti muscles. When it is coming to the medial thigh, they are A double the adductor muscles, and when it comes to the posterior thigh, there are four hamstring muscles. Understand that any muscle which is going to pull the femur anterior crosses the hip joint anterior, like the iliopsoas muscle is the chief muscle of the hip flexion, though it is assisted by some other muscles like sartorius, rectus femoris, and pectineus. Similarly, any muscle which will cross the hip joint posterior, like gluteus maximus, will be pulling the femur posterior for hip extension, and it is assisted by some of the hamstring muscles which are crossing the hip joint posterior, which may be semitendinosus, semimembranosus, long head of biceps femoris, and posterior part of adductor magnus. Understand that the strongest ligament of human body is the iliofemoral ligament attaching to ilium part of hip bone and femur, which is preventing hyperextension of the hip joint. Extension at the hip joint is quite a limited movement, whereas the flexion at the hip joint is quite a large movement. When it comes to rectus femoris, part of the quadriceps femoris, it is working at two joints, as you can understand, pulling the tibia anterior for knee extension and folding the hip joint for flexion, working with iliopsoas. But the first action should always be told as knee extension, because it is majorly a part of quadriceps femoris. It is antagonizing biceps femoris, which is a hamstring muscle. The hamstring muscles, their chief action is pull the tibia posterior for knee flexion, though they are also assisting gluteus maximus for the hip extension. The chief extensor at the hip joint is gluteus maximus, but it is assisted by some of the hamstring there as accessory muscles. Normally, the hamstring will be antagonizing the quadriceps muscle anteriorly. As the hamstrings are contracting, the quadriceps muscle must be passively lengthening or they will be relaxing. There are three glutei muscles, like the largest and the most social is gluteus maximus, though most of its fibers are inserted into the iliotibial tract. There is 25% fibers inserted on the gluteal tuberosity posteriorly on the femur. And gluteus medius is in the middle, and its origin is from the hip bone, but insertion is lateral surface of the greater trochanter. Gluteus minimus is more anterior, taking origin from hip bone and inserted on the anterior surface of the greater trochanter. The gluteus medius and minimus, they are crossing the hip joint anteriorly, so what they do is they will be medially rotating the hip joint, and they can also cause abduction. So abduction and medial rotation is their chief activity, whereas the gluteus maximus is crossing the hip joint posterior, so it is chiefly an extensor at the hip joint. As you can see, posterior view of the gluteal region, especially the right side, you can find that there is a piriformis muscle coming from the greater sciatic notch and inserted on the greater trochanter. And then you can see some quadratus femoris muscle, which is attaching to the hip bone here and to the femur bone there. These are all short lateral rotators. May it be the piriformis or quadratus femoris. These are the short lateral rotators at the hip joint. They are antagonizing the action of gluteus medius and gluteus minimus, which are medial rotators. Let us look at some more short lateral rotators, like it is a piriformis, and then the superior inferior gemini, and also the obturator internus tendon, sandwich between the two. Even the obturator externus was a lateral rotator along with the quadratus femoris. So all these muscles, short lateral rotators, are going to antagonize the action of gluteus medius and minimus, which are medial rotator at the hip joint. This is the piriformis muscle coming from the greater sciatic notch attaching to the tip of greater trochanter, and above that is superior gluteal nerve supplying the three muscles which are the gluteus medius, minimus and the tensor fasciae lata. These three muscles, trio muscle supplied by a single nerve, are doing three activities. We discussed one is abduction of the hip joint, second is the medial rotation, third is they'll help us in walking by stabilizing the pelvis, and they are working like anti-gravity muscle. How, that we'll find out shortly. And as you see, this sciatic nerve is coming through the greater sciatic notch, but below piriformis muscle along with the inferior gluteal nerve. Inferior gluteal nerve is going to supply the large muscle here, gluteus maximus, for hip extension. Sciatic nerve is going to be two nerves running together, and it is a tibial part of the sciatic nerve which is going to supply hamstring muscle. Common peroneal nerve supply the short head of bicep femoris there. And as you see, gluteus maximus supplied by inferior gluteal nerve is for the extension at the hip joint, whereas these trio muscle, gluteus medius, minimus, tensor fasciae lata supplied by superior gluteal nerve, root value L5S1 will be the abductor and medial rotator at the hip joint. Otherwise, all the other muscle, piriformis, obturator, interne, externus, or maybe superior inferior gemellus, they are all short lateral rotator at the hip joint, antagonizing the trio muscle there. Trio muscles that is supplied by superior gluteal nerve will have three actions. We have discussed two of them, abduction, medial rotation, hip joint. The third is to stabilize the pelvis while walking. Normally, the trio muscle working on one side are going to antagonize the gravity on the other side. As we are in the swing phase of walking cycle, when the foot is in the air, the gravity tends to pull the pelvis down, but it is not being pulled down because balanced by the trio muscle on the other side. In case the trio muscles are not working on one side, then the gravity become more powerful and pull the pelvis down. Treadle work test will become positive on this side, and the limb length will be more on this side, and then the patient will have to walk with a lurching gait. As you see, this patient is walking with a lurching gait. There's a bend of the spine, and the patient lurched towards the same side where the muscles were paralyzed. So trio muscles paralyzed on this side, the spine will be bending on that side so that the patient can clear the foot from the ground while walking in the swing phase of walking cycle, because the foot was dragging on the ground. You have to clear it off by bending the spine there, lurching gait. Now, when it comes to sciatic nerve, let us look at the sciatic nerve on the right side posterior gluteal region, and it is coming from the greater sciatic notch below the piriformis muscle. It is two nerves running together, that is the tibial nerve to go with the bone tibia medially, and the common peroneal nerve, which is also called common fibular nerve, to go with the fibula bone laterally, going to the lateral to the neck of the fibula. It is called common because further divides into two branches. One is called as the superficial peroneal nerve going more lateral, and deep peroneal nerve which goes anterior to tibia. Hence, it is also called as anterior tibial nerve, whereas the actual tibial nerve which reaches posterior to tibia will be continuing as posterior tibial nerve in the calf region. Here, for hamstring muscles, which are posterior thigh muscles, basically semitendinosus, membranosus, and the long head of the bicep femoris, plus posterior part of rectus magnus will be supplied by the tibial part of the sciatic nerve, whereas the short of the bicep femoris is supplied by common peroneal nerve, thus making the bicep femoris a hybrid muscle. When it comes to the anterior aspect, you will find this is the anterior aspect of the right lower limb, and there are two nerves to talk about. There is L234. It is the dorsal division giving the femoral nerve to supply the quadriceps femoris here, the four muscles, one rectus, three vastus, and the femoral nerve is a nerve of knee extension by pulling the tibia anterior, whereas the L234 ventral division will be giving you obturator nerve, passing the obturator foramen and coming to medial thigh, supplying the ADD erector muscles. They are doing thigh adduction at the hip joint, but be careful about the obturator externus, which is also supplied by obturator nerve, the nerve of medial thigh, but it is not adductor, it is a lateral rotator at the hip joint. When we are talking about the thigh, it is upper thigh, mid thigh, and the lower thigh. In the upper thigh, there is a femoral triangle. In the mid thigh, there is a adductor canal. In the lower thigh, you have a popliteal fossa. There will be femoral artery in the femoral triangle, continuing as femoral artery in the adductor canal, but becoming the popliteal artery in the popliteal fossa. In the popliteal fossa, you'll have popliteal vein, which will then become femoral vein in the adductor hiatus, and then continue in the adductor canal and in the femoral triangle also. So femoral triangle has femoral artery and femoral vein. They are also continuing in the adductor canal, femoral artery, femoral vein, but in the popliteal fossa, they become popliteal artery and popliteal vein. Now, there is individual nerve in the three parts of the thigh. In the femoral triangle, you have the femoral nerve, but it stops there, and in the adductor canal, it will be giving a branch, a cutaneous branch, which is called saphenous nerve branch of the femoral nerve. Femoral nerve do not come to the adductor canal, but this branch, saphenous nerve, come here, and when it comes to the nerve of the popliteal fossa, they will have the tibial nerve. When we take a section of the mid-thigh, there you can see adductor canal, which is having a roof of the sartorius muscle, a floor of the adductor magnus and longus there. Let us magnify this area of the adductor canal. As you do that, you will find that we again see the sartorius as the roof and adductor longus magnus as the floor and vastus medial as the anterolateral boundary of the adductor canal. In the adductor canal, you have the femoral artery and femoral vein, but not the femoral nerve. It is actually a branch of the femoral nerve, which is called saphenous nerve, running in the adductor canal. Talking about the popliteal fossa, it is a diamond-shaped structure on the posterior aspect of the knee joint, and you'll find it has a superolateral, superomedial boundary, infralateral, infromedial boundary. The superolateral boundary is the long head of the bicep femoris, which is inserted on the head of the fibula, and superomedial are the other hamstrings like semitendinosus, semimembranosus, inserted on the tibia bone medially. Inferiormedially, inferiorlaterally are gastrocnemius thigh muscle, and laterally you can also have the plantaris muscle as the inferior-lateral boundary. You will see the content are femoral artery, femoral vein passing adductor hiatus, and then they have become the popliteal artery and popliteal vein. You will find that tibial nerve is a content of the popliteal fossa, whereas the common penile nerve is under cover of the bicep femoris and keep running at the margin, which is superior lateral margin of the popliteal fossa. At the floor of the popliteal fossa, we have popliteus muscle supplied by the tibial nerve there. This is a case of a triple triad injury in a football player when the foot was fixed to the ground and knee was in flexion. There is a twisting fall to the same side. 3 ligaments have been compromised, which are ACL, anterior cruciate ligament, and the medial meniscus and the tibial collateral ligament, which is also called medial collateral ligament. Let us look at the more details of these ligaments now. As you're looking at the front view of the right knee joint, this is the right femur and right tibia, and this is the right fibula, but fibula is not participating as such in the knee joint. It is basically the joint between femur and the tibia. Now you will see that there are some fibrocartilaginous structures called as the lateral meniscus and medial meniscus, which are working like a shock absorber between the femur bone and the tibia bone here. And then you will have ACL and PCL. ACL is called A because anteriorly attaching to tibia bone and running backward, upward, lateral, attached on the middle aspect of the lateral femoral condyle. It is preventing posterior displacement of femur on the bone tibia. Whereas the PCL is attaching posteriorly on the tibia and comes to the medial condyle of the femur and attaches on the medial aspect of the medial condyle of the femur. As you are talking about the tibial collateral ligament, which is attaching extracapsular, and it is on the medial side, so medial collateral ligament is the other name. You can also see when you are looking at the superior surface of the tibia, various ligaments are attaching. They have a particular sequence you can remember. Anterior to posterior, Medical College, Lucknow Medical College. So what is the most anterior? It is the medial meniscus, so medical. And then it is the C, that is anterior cruciate ligament, and then it is the L, that is lateral meniscus, and then again it is the lateral meniscus, and then you have the medial meniscus and the posterior cruciate ligament. Understand, posterior cruciate ligament is attaching posterior on tibia, anterior cruciate ligament is attaching anteriorly on tibia, and the lateral meniscus, which is fibrocartilage, is more of a circular fashion, so anterior posterior horn of the lateral meniscus come very close to each other, whereas the medial meniscus is C-shape and the horns anterior posterior are slightly wide. So you can just remember Medical College, Lucknow Medical College, that is sequence of attachment of the various ligaments on the intercondylar ridge on the superior aspect of the tibia bone. And this is the most anterior thing, which is the ligamentum patella attaching to a tibial tuberosity more anteriorly, but it is not on the superior surface of the tibia as such. And as we have already mentioned, the ACL attaches anteriorly on the tibia and then backward, upward, lateral towards the bone femur. It is the ACL which is preventing posterior displacement of femur and limiting the hyperextension at the knee joint. On the other hand, PCL is attaching posterior on tibia and running towards the femur anteriorly, and it is the PCL which is preventing the anterior displacement of the femur on the bone tibia, and it is working during the flexion at the knee joint. When there is an ACL tear, we are able to pull the tibia anterior because it has become loose. Normally, you cannot pull the tibia anterior as you are seeing the anterior droid test being conducted here. The patient is supine and 90-degree knee flexion. You are trying to pull the tibia anterior. You cannot because it is prevented by ACL. But if there is an ACL tear, like in that football player with tibial triad, then tibia is loose and you can pull the tibia anterior. Talking about the knee locking, it is the quadratus ephemeris muscle, which is for knee extension. And if you continuously work upon the quadratus ephemeris, then you will cause a full knee extension, which is required for standing straight. Now, if your foot was fixed to the ground, what happens during the last stages of knee extension is the femur will rotate medial and the knee will be locked. But if your foot is in the air, which is very rare, maybe you are sitting on a table and hanging your foot down, so foot is in the air, and at that time you were doing the full knee extension, and that is also knee locking. That time the tibia will rotate lateral and the knee will be locked. Now, maybe you are rotating femur medial when the foot is fixed to the ground, or maybe you're rotating tibia lateral when the foot is free in the air. You are locking the knee joint. In knee locking, what happens is the tibial tuberosity will go towards the lateral border of the patella. Now, in this belly dancer, as you can see, the foot is fixed to the ground here. If you want to do the knee locking, then femur must have rotated medial and the knee locked. When the foot is in the air, the tibia must have rotated lateral and the knee got locked. But in routine life, most of us will be keeping the foot on the ground and keep rotating femur medial. To keep the foot in the air, it is rare, and then you are doing the knee locking. So if you have to choose femur rotating medial is a better answer than tibia rotating lateral for knee locking. Now here we have taken a transverse section of the leg region on the right leg, and you will see three compartments. There is anterior leg compartment, there is posterior leg compartment, and lateral leg compartment. Lateral leg compartment, you have peroneus longus and peroneus brevis, which will turn the sole lateral. They are the foot everters at the subtalar joint, whereas the anterior leg muscles are extensor or dorsiflexor muscles. They take the foot up. And the posterior calf muscles are in two groups, that is superficial and the leg group, and they are basically plantar flexure. Take the foot down. Now, you can remember one mnemonic: Tom, Dick, and Harry, anterior and posterior. The anterior Tom, Dick, and Harry is extensor Tom, Dick, and Harry, and posterior is the flexor Tom, Dick, and Harry. The Tom, which is anterior, is tibialis anterior muscle, and then along with that, there is extensor of the great toe and extensor of other toe. So, extensor hallucis longus and extensor digital longus. So, Tom, Dick, and Harry, which is extensor on the anterior side. Similarly, there is a Tom, Dick, and Harry on the posterior side. The tibia, this posterior is behind the tibia, and then you have the flexor hallucis longus and flexor digitorum longus. So they are kind of a mirror image. If you look at the superficial muscles on the posterior calf region, then they are GPS muscle, G for the gastrocnemius, P for the plantaris, S for the soleus. They have a common tendon, which is tendo-Achilles, and you've hit the tendo-Achilles, that is ankle reflex, then there'll be a plantar flexion. Now, taking the foot up, which is dorsiflexion or extension, is done by the anterior leg muscle, which are 4 in number. Though we have discussed only Tom, Dick, and Harry, there is one more muscle. Let us talk about all the 4 muscles doing the dorsiflexion then. And when it comes to plantar flexion, there will be total 6 muscles working, 3 superficial and the 3 deep. The superficial muscles are the GPS muscle, and the deep muscle are Tom, Dick, and Harry, but they are flexor Tom, Dick, and Harry. First, we will be focusing upon the anterior Tom, Dick, and Harry, the extensor Tom, Dick, and Harry. As you can see here, this is a muscle in front of the tibia, so tibialis anterior, and then you have the extensor hallucis longus for the great toe, extensor digitorum longus for the other toes, and there's a peroneus tertius also. Peroneus tertius muscle, though it is an everter at the subtalar joint, but it is also working with the anterior leg muscles for the dorsiflexion or the extension at the ankle joint and the toe joint. And you can see there are 2 extensor retinaculata. The inferior one is Y-shaped to keep these tendons close to the bone so that you have good movements of extension. And the muscles, as we said, is tibialis anterior, and then there's extensor digitorum longus, extensor hallucis longus, and the fibular or the peroneus tertius. As all of them are surrounded by deep peroneal nerve, which is also called antiotibial nerve. They are the nerve of dorsiflexion or extension. Though, understand that tibialis anterior is an inverter, powerful inverter, whereas peroneus tertius is additionally an everter. So both of them will be antagonizing, but if they work together, they'll definitely do dorsiflexion or extension at the ankle and the toe joint. Now, when it comes to the posterior calf region, there is 3 muscles which are superficial, and they are called as the GPS muscle, having a common tendon, which is the Achilles tendon. This is also called triceps surae muscle. The G for gastrocnemius, P for plantaris, which come from the lateral aspect, and then S is the soleus. If you hit the tendon of the Achilles or tendo-calcaneus, there will be a plantar flexion. Now, this is having a root value H1, the ankle reflex, and GPS muscle have the H1 root value. As you can see, G for gastrocnemius, P for plantaris, S for soleus, having the tibial nerve, which is actually called posterior tibial nerve because running behind the tibia, and that is for plantar flexion. And then as you remove the three superficial muscle, you see the deep muscle, and the deep muscles are Tom, Dick, and Harry, but they are flexor, Tom, Dick, and Harry. You can see tibialis posterior here, along with the flexor hallucis and the flexor digitorum longus. These tendons are passing under the flexor retinaculum on the medial aspect of the ankle, and which is holding the tendon close to the bone so that you can have good movements. And as you can see, flexor hallucis longus or digitorum longus, tibialis posterior, they are all supplied by tibial nerve, which is posterior tibial nerve, in fact. And then you can see that as the tibialis anterior was an inverter, even the tibialis posterior is inverter. So there are two, both of the terms are inverters, whereas the posterior term is a plantar flexor and anterior term is a dorsiflexor. The lateral compartment of the leg has the peroneus longus and peroneus brevis muscle. Peroneus longus muscle is also working like a stabilizer for the lateral longitudinal arch. Lateral longitudinal arch of the foot, which is, foot is not flat, it is elevated slightly for good weight transmission to the ground and also for running and jumping. Though lateral longitudinal arch is not as important as the medial longitudinal arch, but lateral longitudinal arch is maintained by the peroneus longus tendon, which is passing under the foot bones, and also some short plantar ligaments laterally. In the lateral longitudinal arch, you will see the bones involved are the calcaneum, and then it is the cuboid bone, and there is a CC joint, which is calcaneocuboid joint, saddle synovial joint, the joint of the lateral longitudinal arch. Also, metatarsal number 4 and 5 forming anterior pillar. Anterior pillar is metatarsal number 4, 5, and posterior pillar is the calcaneum bone, and this is the arch. You want this arch because of good weight transmission of the body to the ground and for running and jumping. When you talk about the two everter muscles, they are turning the sole outside, and their names are the peroneus longus brevis. When you talk about the two inverters, they are turning the sole inside, and they are both the term, maybe tibialis anterior or tibialis posterior. So both the term will be antagonizing both the peroneal muscle, and they work at the subtalar joint under the talus, talocalcaneal joint basically. Now looking at the front view of the right leg, you will find that there is a common peroneal nerve, which is a part of the sciatic nerve coming lateral to the neck of fibula and dividing into two. There is a superficial branch which is going to the lateral leg compartment. There is a deep branch which is coming anterior tibia. Now the superficial peroneal nerve which goes lateral leg compartment supply the lateral leg muscles, peroneus longus brevis, which will turn the sole lateral. So superficial peroneal nerve is a nerve of foot eversion and supplying most of the skin on the dorsum of the foot. Whereas the deep peroneal nerve, which is also called antitibial nerve because it is passing anterior tibia, supplying the Tom, Dick, and Harry, which are extensor Tom, Dick, and Harry, and it is a nerve of dorsiflexion or the nerve of extension. As you see, if a deep peroneal nerve, or which is called antitibial nerve, damaged, there will be a foot drop, which is loss of dorsiflexion. Though foot drop can also come due to injury of the common peroneal nerve. But then, if there is injury of common peroneal nerve, there will not only be foot drop, loss of dorsiflexion, there is also loss of the foot eversion and sensory loss on the dorsum of the foot. Remember, most of the skin on the dorsum of the foot is supplied by superficial peroneal nerve, except dorsum of the first left space, which is supplied by deep peroneal nerve, which is also called anterior tibial nerve. Root value is L5. So great toe is always L5. That is the root value of the deep peroneal nerve. And also remember, dorsiflexion is done by deep peroneal nerve, so that is also L5. Now look at the posterior aspect of the leg region, the calf region, and as you will find, the sciatic nerve is two parts. We have already discussed common peroneal nerve. We are now talking about the tibial nerve. Tibial nerve in the popliteal fossa will supply the popliteus muscle, which is for the unlocking of the knee joint and also for initiating the knee flexion along with the hamstring. Then this tibial nerve goes behind the tibia bone called posterior tibial nerve, supplying 6 muscles there. The GPS muscle, which are superficial for plantar flexion, and then Tom, Dick, and Harry, which is flexor Tom, Dick, and Harry, which is tibialis posterior, flexor digitorum longus, flexor hallucis longus. And then this posterior tibial nerve is passing under flexor retinaculum, which is on the medial aspect of the ankle, dividing into two branches, which is lateral and medial plantar nerve, which is going to supply the skin of the sole and muscles of the sole. The tibial nerve also has a cutaneous branch, which is called as the sural nerve, which is running lateral to the margin of the foot and supply little toe. That is the S1 dermatome. Remember, the posterior tibial nerve is having root value S1 for the dermatome, little toe, and it is also having S1 myotome for plantar flexion. The posterior tibial nerve, which is S1 for plantar flexion, is antagonizing the anterior tibial nerve, which is L5 for dorsiflexion. If there is injury of common nerve lateral to the neck of fibula, we have discussed there will be three problems that is shown here. This patient will be having difficulty in dorsiflexion, so there will be a foot drop. And number two, there will be difficulty in eversion. And number three, there is sensory loss on the dorsum of the foot, but it is also extending to the lateral aspect of the leg. The territory of common peroneal nerve is lateral to the knee, and territory of the social peroneal nerve is lateral leg aspect. And also most of the dorsum of the foot, except the dorsum of the first vertebral space, which is actually supplied by deep peroneal nerve, all will have sensory loss if there is injury of the common peroneal nerve lateral to the neck of fibula. That could be a blunt injury, or it could be due to a POP cast which have been put tightly below the knee. As we talk about the nerve supply of the lower limb, cutaneous supply, it is basically femoral branch of the genitofemoral nerve in the anterior medial thigh along with the ilioinguinal nerve. When it comes to the medial aspect medial thigh, it is obturator nerve. Otherwise, it is the branches of femoral nerve, which is anterior and lateral cutaneous branches of the femoral nerve. If you go still more lateral, then there could be the lateral cutaneous nerve of thigh. And when it comes to the medial aspect of the leg region, including the medial malleus, it is the saphenous nerve, branch of the femoral nerve. When it comes to the lateral aspect, we have discussed already, lateral to the knee joint, it is common peroneal nerve, otherwise social peroneal nerve, and it is supplying most of the dorsum of the foot, except the little toe area, because that is sural nerve, branch of the tibial nerve. When it comes to the dorsum of the first web space, it is the deep peroneal nerve with alpha dermatome. Be careful now about the medial aspect, because saphenous nerve will never reach the great toe. So great toe medial aspect is supplied by superficial peroneal nerve there, whereas the lateral aspect of the great toe will be supplied by deep peroneal nerve. Looking at the medial aspect of the ankle joint, the lower end of the tibia bone, that will be the medial malleus, and there attaches the deltoid ligament with four parts. Below the tibia bone, you have the talus bone. As you can see here, this is the lower end of the tibia, the medial malleus. Below that is talus. Below talus is the calcaneum, and between the two is subtalar joint. And at the subtalar joint, you have two everter working. The inverters are the tibialis anterior posterior, and everter are the peroneus longus and the brevis. Medial bone is the navicular bone, and there is a talocalcaneal navicular joint here, which is ball and socket joint, which is working for the medial longitudinal arch here. As we were talking about the deltoid ligament, it has four parts, all attaching to medial malleus or lower end of the tibia, and their names are always having the prefix tibia, like anterior tibiotalar, posterior tibiotalar, tibiocalcaneal, and tibionavicular. So these are the four parts of the deltoid ligament. Remember, spring ligament is not a part of the deltoid ligament, though it is fused with the deltoid ligament. Here is the flexor retinaculum we were talking about on the medial aspect of the ankle, attaching to the calcaneum bone and the medial malleus, and under that is going the Tom, Dick, and Harry. You will see that they are the tendons and the nerve vessels coming from the calf region. So what is most anterior is the Tom, which is tibialis posterior. Then behind that is flexor digitorum longus, which will be flexing the toes. And then you will see that there is an artery, posterior artery, followed by posterior nerve, and the Harry, the flexor Harry, posterior Harry, and flexor hallucis longus will be flexing the great toe. They all pass under flexor retinaculum. As the posterior nerve come here, it can be compressed. It is called tarsal tunnel syndrome, and compromising the branches in the sole, which are called medial lateral plantar nerve. There will be sensory loss on the sole, and some of the muscle of the sole may not be working if there is a compression of posterior nerve under flexor retinaculum, tarsal tunnel syndrome. Now we are looking at the medial longitudinal arch, which is contributed by the calcaneum again, and then there is a talus bone and navicular bone. Also, you will see there are three cuneiform bones, and then the first three metatarsal, tarsal number 1, 2, 3, and their heads are working as the anterior pillar. So three metatarsal, three cuneiform, and then it's the navicular bone, medial bone, and talus and the calcaneum. This is a medial longitudinal arch, which is more important, more arched, and we require these kind of arches for running and jumping, and also distribution of the weight properly on the ground. The medial longitudinal arch is maintained by various ligaments and tendons. The tendons of the muscles are dynamic support, whereas the ligaments are basically passive support. As we talk about the spring ligament, which is plantar calcaneonavicular ligament, which is supporting the head of talus, also is a passive support for medial longitudinal arch. Even plantar aponeurosis, which is holding posterior pillar calcaneum close to the anterior pillar, that is head of the metatarsal, maintaining the arch. So we know the two passive support now, plantar aponeurosis hallucis, and also the spring ligament. But as you were talking about the dynamic support, let us discuss two of them. There is the anterior term and posterior heri. The anterior term is tibialis anterior and posterior heri is the flexor heri. The flexor hallucis longus coming from the calf is hooking under the sustentaculum talus on the calcaneum bone and pull the great toe for flexing the great toe. Now what the flexor hallucis longus or the tibialis anterior do is they are working like slings and they pull the middle bone up. As you pull the middle bone up, you will maintain the arch, and somehow if these tendons are cut, the middle bone will fall down. There will be a flat foot. Talking about the muscles in the sole, we have 4 layers, and if you remove the first layer, you see the second. If you remove the second layer, you see the third, and if you remove the third, then you see the deepermost 4th layer, which is muscles between the bones. So deep they are. So they are called as interossei muscle. Like in the hand, there in the foot you have interossei, but there are only 3 plantar interossei and 4 dorsal interossei. As you see, interossei in the 4th layer are the lumbricals. Lumbricals are in the second layer, which are coming from the tendon of the flexor digitorum longus coming from the calf region. The lumbrical and interossei together, what they do is they'll be causing flexion of the metatarsopharyngeal joint and extension of the interpharyngeal joint. If the lumbrical interossei were paralyzed, then there'll be a claw foot deformity like you have claw hand deformity in the upper limb. Now, what is claw foot deformity? It is the hyperextension of the MTP joint and the interpharyngeal joint flexion. Because the sole muscle, lumbrical interossei, are not working in the second layer and the 4th layer, what happens is anterior leg muscle, posterior calf muscle become more powerful. The anterior leg muscles or posterior calf muscles were normally balanced by the lumbrical interossei. Like in the upper limb, the lumbrical interossei are balanced by the forearm muscle. In the lower limb, the lumbrical interossei foot are balanced by the posterior anterior leg compartment. So, who is causing this interpharyngeal flexion of the toe? That is the flexor Tom, Dick and Harry coming from the calf region. And who is causing this MTP hyperextension? That is the anterior Tom, Dick and Harry or the extensor Tom, Dick and Harry. And remember one muscle in the first layer for the great toe, which is called AB, abductor hallucis, and one muscle for great toe in the 3rd layer, which is ADD, adductor hallucis. This will help you answer some of the MCQs. This is what we were talking about, the claw foot deformity, which might be happening due to the paralysis of lumbrical interossei. I am suggesting that the lumbrical interossei are normally balanced by anterior and posterior leg compartment muscle. And if lumbrical interossei are paralyzed somehow, like there is injury of the posterior tibial nerve supplying the sole muscle, the medial lateral plantar nerve are compromised in the tarsal tunnel syndrome, leading to claw foot deformity. Why do you have this metatarsopharyngeal joint hyperextension? Because of the anterior leg muscle, which is the extensor Tom, Dick and Harry. And why you have the interpharyngeal flexion here? Because of the posterior Tom, Dick and Harry, which is flexor Tom, Dick and Harry. So they will be causing interpharyngeal flexion here, claw foot deformity. Now we are talking about the arteries in the upper limb, and as we can find, there is abdominal aorta bifurcating into common iliac artery, bifurcating into internal external iliac artery. Internal iliac artery anterior division will give obturator artery to the medial thigh, whereas the external iliac artery passing under the inguinal ligament will continue as the femoral artery. Femoral artery is the artery of the anterior thigh and giving a branch profunda femoral artery, which is going to the posterior thigh. So posterior thigh you have profunda femoral, anterior thigh femoral artery, and medial thigh you have obturator artery. But the chief artery for the thigh region is profunda femoral artery because it supplies posterior thigh as well as anterior medial thigh. Now this femoral artery passes the adductor hiatus and then comes to the popliteal region, become popliteal artery, and in the popliteal region it will giving 2 superior genicular, 2 inferior genicular, 1 middle genicular to supply the knee joint, and then it will give 2 branches, anterior tibial artery which will run anterior tibia and then tibio-peroneal trunk. Tibio-peroneal trunk is dividing further into 2, posterior tibial artery and the peroneal artery. Now the anterior tibial artery comes to the dorsum of the foot and from the dorsalis pedis artery, whereas the posterior tibial artery will go to the sole and form medial lateral plantar arteries there. As you can see here, this is the popliteal artery which is giving us the tibio-peroneal trunk, and there's a posterior tibial artery which is going to pass under the flexor retinaculum along the posterior tibial nerve, medial side of the ankle, and give medial lateral plantar artery to the sole. Peroneal artery is going to supply the lateral leg compartment muscle, but remember the artery is remaining in the posterior leg compartment only, means it is not going to lateral leg compartment, though it supplies the muscles of the lateral leg compartment. And the anterior tibial artery comes anterior to the tibia, and then it forms the dorsalis pedis artery on the dorsum of the foot. Understand that femoral artery gave the profunda femoral artery of the posterior thigh. It is giving medial and lateral circumflex arteries, and medial lateral circumflex artery medial is more important to give the retinacular arteries towards the head of the femur bone, and though head of femur is also supplied by other arteries like obturator artery, but if there is intracapsular fracture of the neck of the femur, then there is avascular necrosis for the head of the femur, because it will compromise the adventicular arteries, which are the chief artery to the head of the femur, and they are coming from the medial circumflex femoral artery. When it comes to the vein, there are two types of veins, superficial, subcutaneous, and the deeper veins. Deeper veins will have same name as the arteries. So you can tell there is a peroneal artery, which is supplying the lateral leg compartment. There's anterotibial artery, which is supplying anterior, posterior artery, supplying the posterior calf region. So similarly, there'll be veins, peroneal vein, anterotibial vein, and posterior vein. They join to form the popliteal vein, which will then continue as the femoral vein, will become the external iliac vein, and join the internal iliac vein to form common iliac vein, and common iliac vein on both the sides join to form the inferior vena cava. This is about the deeper veins. What about the superficial veins? There is a dorsovenous arch which will continue medially as the great saphenous vein, which will be then draining into the femoral vein there medially, and then the dorsovenous arch laterally will continue as the short saphenous vein, which will run on the lateral aspect of the leg, posterior side of the leg, and enter the popliteal vein at the roof of the popliteal fossa. Now the superficial vein must drain into the deeper veins, and there is a mechanism to prevent backflow of the deeper vein into superficial vein. There are some perforators, there are some valves. We have to talk about those perforators now. So as you will see that there is a supra-ankle Cockett's perforator, which are connecting the posterior arch vein with the superficial veins, like you have the great saphenous vein here. Great saphenous vein, as it continue upward, you will see there's a below knee perforator, which is B for B. Below is the Barrett's perforator. It is connecting the great saphenous vein with the popliteal vein. When it comes to above the knee, which is Dodd's perforator, you'll find that it is connecting now the great saphenous vein with the femoral vein. And if you go to the mid-thigh, there is a Hunterian perforator in the mid-thigh and connecting the great saphenous vein with the femoral vein. Basically, these perforators, they have valves which are preventing blood of the deeper veins to enter the social veins. If there is a incompetency of the valve, then the deeper veins will send the blood into social vein, and the social veins like great saphenous vein will be dilated, elongated, tortuous, forming the varicose vein and varicose ulcer near the medial malleus. Now, it is kind of a summary for the lower limb, leg compartment. There is the anterior compartment we were talking about. There are four muscles. There is a Tom, Dick, and Harry. The tibialis anterior, extensoris longus, extensoris longus, and peroneus tertius. Remember, in this compartment, we have the anteriotibial artery and the anteriotibial nerve, which is also called deep fibular nerve. But if you're talking about the lateral leg compartment, there is a peroneus longus brevis, but there is only social peroneal nerve, the nerve of the foot eversion. There is no artery in this compartment because the fibular artery is actually in the calf region. The calf region has two parts, superficial and the deep part, and superficial part, which is having the GPS muscle, has no neurovascular bundle. Neurovascular bundle is present only in the deeper calf region, and that is where you have the Tom, Dick, and Harry. This Tom is tibialis posterior, and then you have flexor muscle, which is flexor digitorum longus and flexor hallucis longus, and that is where you have posterior tibial nerve. Along with that, there is a posterior tibial artery, and also the peroneal artery lies here. Though it is supplying the lateral leg compartment, do not go to lateral leg compartment, stays in the calf region only.